I think 35 people have joined.
Yeah, we are
Start.
yes.
We can start, madam.
Yes. Good afternoon and welcome to this unique webinar on complications management in diabetes. सर्वप्रथम एक गोष्ट आपल्याला लक्षात ठेवायला पाहिजे की आजपासून श्रावण महिना सुरू झाला आहे आणि आपल्याकडे सगळं गोडधोड सुरू होत आहे. परंतु तर त्याकरताच आपण द व्हेरी फर्स्ट डे ऑफ द श्रावण वी हॅव केप्ट दिस टॉपिक ऑफ कॉम्प्लिकेशन्स and how to manage these cardiorenal complications in diabetes. So be aware of all the sweets which will be tempting you for all this whole month and again in further 3-4 months. So with this small introduction, I will hand over my mic to our president, Madam Dr. Meenakshi Deshpande.
Yeah, thank you. And at the outset, let me thank AstraZeneca for a wonderful webinar series on diabetes, which they are doing every month. And it is with a real dedication that they are doing this series on diabetes. So it really shows, and with IMA Pune, we really want to bring it out that diabetes is the killer of this century. And we have to do something to keep diabetes under control. Even now, just in past 2 or 3 days, I have diagnosed 4 new patients with diabetes, with sugars 325, 326, and 425 with no complaints as such of the patient. Patient had come to us only with backache. And when we did a fasting PP sugar, it was coming 325 and 436. And this itself shows how the diabetes is increasing rampantly all over Indian citizens. And yes, we should do something to diagnose diabetes at a very early stage. And even when the patient comes with no proper complaints of diabetes, I think it is very much advisable to do a fasting P sugar, hemoglobin A1C at the initial visit of whenever the patient comes to your clinics or OPD. With this introduction of diabetes in our day-to-day practice and the importance of diagnosing and treating diabetes at a very stage, I would also like to bring to your notice a interesting and a very exciting 2-day conference of Women's Doctors Wing of IMA Maharashtra State, which is being hosted by IMA Pune on 27th and 28th of August. We have been sending you the circulars and the registration links. But I think many people are thinking that, yes, it is only a webinar conference of women. But that is not so. Just please remember, it is a theme of women's health. But the conference is open to all IMA Pune members. It's open to all non-IMA members also. And it is open to IMA accompanying persons. And so you can rarely register and look forward to an excellent academics, a nice cultural evening, and excellent bonanza of different topics which are handled by different experts. We are just releasing the scientific program flyer now, and we will be sending it to all our esteemed members of IMA Pune. So please register in large numbers, because this is not only a conference for women, it is the conference dedicated to women's health. And women's health is a topic of day-to-day practice. It is an important topic for day-to-day practice. Because not only we get women as patients, we get women as our colleagues, we get women in your own offices, and you have got women all over you surrounding. So for their health, you must attend this conference. So we will be sending out again from this Sunday onwards the registration link, because past only 3 days are remaining for concessional registration. So please work out on this and attend and plan. And yes, now I'll hand over the mic to Dr. Alka Madam again for the next proceedings. So wishing you all a nice Shravan Mahina with minimum diabetic complications. Thank you so much.
Thank you, Madam. And I welcome Dr. Manoj Durairaj, Dr. Bharat Salve, Dr. Jagjit Deshmukh, who is the first speaker. And sir, good afternoon to all. we'll be starting the session now. So without wasting our time, because everyone has been allotted a 30 minutes talk, and I think it's actually a injustice to all of them, because they are all eminent speakers and very thorough clinicians. So first I will start with Dr. Jagjit Deshmukh. Sir, he's a MD, DM, FE, SC, consultant cardiologist. He has a vast experience in the field of interventional cardiology procedures like angiography, coronary angiography, coronary angioplasty, intravascular ultrasound, fractional flow reserve, pacemaker. And Dr. Deshmukh sir, he is one of the few cardiologists who is trained in advanced echocardiography techniques like transthoracic and transesophageal 3D echocardiography. He has many publications in the reputed national and international cardiology related journals. He is actively working in Sahyadri Hospital, Pune, apart from many other cardiac centers in East Pune. He is also visiting cardiologist in Niramay Hospital, Paris Hospital, Usmanabad, Suvidha Hospital, Barshi, and other centers in nearby area. His special interests are in primary PCI in myocardial infarction and heart failure emergencies. Sir, over to you. Your topic is lowering risk of stent thrombosis, learning from a case. So over to sir. Sir, good afternoon, sir, and welcome, sir.
Thank you, madam. And I would like to thank the Indian Medical Association for providing a dais to all of us. It's been pleasure to discuss something about cardiology in relation to diabetes, and without wasting time, I'd like to share my case, a typical case, which is hypothetical, and how this can be managed in our clinical practice. So this is my screen visible, ma'am?
No, sir.
Yeah. Yes, now it is.
Okay. So this is a case of a 56-year-old gentleman who is.
Sir, please, sorry. Yeah.
So this is a 56-year-old gentleman who has been diabetic, and he suffered an acute myocardial infarction. He used to have smoking, and he has a history of smoking. His ECG shows there is an escalation MI. He went to a cardiologist. His angiogram revealed the blockage in the LED, which is totally occluded. He was treated with the aspirin and ticagrelor loading doses. He successfully underwent angioplasty to do LED with drug-eluting stent and was discharged on ticagrelor 90 mg twice a day and aspirin. But after 3 months, the patient was switched from the clopidogrel, switched to clopidogrel 75 mg without loading. 8 days later, the patient suffered a recurrent chest pain, and his ECG revealed that patient has again a re-MI or repeat myocardial infarction. So this is his ECG, which was been there after 3 months. It clearly shows re-MI and triple MI. He again went to the cardiologist with cardiologist did an angiogram, which revealed that the patient is having stent thrombosis, which appeared 8 days after the patient was switched from ticagrelor to clopidogrel. So this reveals that the LED, this stent is totally occluded. LED stent is totally occluded from the beginning. So cardiologist did balloon angioplasty after intravenous tirofiban and established the coronary flow, which is good, and patient was subsequently discharged with good medications. So what is this? This is actually called as stent thrombosis. So why preventing stent thrombosis is a priority for the doctors? Because as like a myocardial infarction, a re-MI or stent thrombosis is associated with a significantly higher risk of lethal outcome. And at the 30 days, occurrence of stent thrombosis can increase the risk of another major cardiac event by 70 times and re-MI by 21 times. So as far as stent thrombosis is concerned, the stent thrombosis risk is significant. ST is associated with the significantly 4 times higher mortality, that is 23% versus 6%. The greatest impact on the mortality was observed in case of subacute, that means less than 1 month, and late, that is more than 1 year. So stent thrombosis occurs relatively frequently. So beyond the first year, it risk reduces, but can be seen up to 6 years. So what are the factors which causes the repeat event or stent thrombosis after doing successful angioplasty? There are a lot many factors. It may be patient factor, it may be procedure related, it may be lesion characteristic, or it may be related to stent. So what are the factors which are related to patients? So these are important from the physician perspective. Suppose if patient is having IMA, like in this case, that's acute coronary syndrome, or if patient was prematurely stopped dual antiplatelet drug, like in this case, which was switched to the clopidogrel without loading, then comes the clopidogrel non-responsiveness, having a heart failure or low ejection fraction, if the patient is actively smoker, or having a history of diabetes, like in this case, or having malignancy. These are the factors the physician needs to consider, and these patients are very likely to have the stent thrombosis. So we need to manage these patients very cautiously. Apart from that, from the cardiologist perspective, if the stent's been not expanded properly, or if there is dissection, or if the lesions proximal LAD or multiple stents are there, if bifurcation is there. So these are the procedure and lesion factors which from the cardiologist perspective are important. And these are stent related factors. If patient has stent fracture, multiple stent, or long stent length, then these patients needs to consider for aggressive management of antiplatelet therapy. So back to the case, this patient was found to be CYP2C19 reduced functional allele, that is non or low responder to clopidogrel. Additional ischemic risk factors like smoking and diabetes was present in this case. This patient was shifted to clopidogrel without any loading. So clopidogrel was again switched back to ticagrelor, that is 90 milligram 2 times a day, and he was discharged after 4 days. So as far as clopidogrel resistance is concerned, why clopidogrel resistance needs to be considered? Because global studies have shown that almost 44% of the population has some form of resistance to clopidogrel. This study from India, that is Indian Heart Journal, Dr. Guha has shown that almost 1 in 3 patients has either partial or complete resistance to clopidogrel. So in such patients, it's important that we need to consider the other dose, other medications, because sometimes some may argue that higher doses of clopidogrel can overcome the resistance. No, this gravitas trial has shown that even the higher doses of clopidogrel may not change the outcome in this scenario. So then comes the role of other medications. So as far as this physiology of platelets is concerned, we know that the platelets are released from the megakaryocytes in bone marrow, and these immature platelets are more likely to have dense granules versus the old circulating platelet, and they are more likely to be associated with the cardiovascular event than the older platelets. So this graph shows that the immature platelet concentration in healthy subject versus patient who had myocardial infarction or acute MI. So you can see that the level of immature platelet, fraction of immature platelet in circulation is high in patients with acute coronary syndrome. So the theory of immature platelets and twice a dose of ticagrelor says that ticagrelor as a molecule has a reversible binding, and twice a dose helpful in patients with acute coronary syndrome, because high platelet turnover and reactivity in patients with coronary artery disease in setting of ACS with high risk factor, like in case is diabetic. This immature platelets needs to be addressed, which is not seen with other antiplatelet molecule. So accelerated platelet turnover and increased generation of immature platelet occur in patients with CAD, in case of acute coronary syndrome, and high risk factors like diabetes or CKD. So this is a pictorial explanation of differences in platelet binding between the thienoparatines, that is clopidogrel, and ticagrelor. So thienoparatines bind, both of them are inhibits the platelet, but they have the different binding sites. So initial binding of the clopidogrel or prasugrel inhibits the platelet irreversibly, but the newly manufactured platelets are not inhibited. On the contrary, twice daily dosing of Brilinta or ticagrelor inhibits the platelet before the next dose. So this graph again shows that accelerated platelet turnover is associated with increased generation of immature platelets, and the twice daily dosing of ticagrelor, like this is the first dose and this is second dose. So irreversible binding and long half-life results in prolonged availability of the ticagrelor to inhibit the immature platelet, which is very essential in ACS patients. So once daily dosing is insufficient in patients with high platelet turnover, like in acute coronary syndrome, young immature platelets are less inhibited by prasugrel or clopidogrel when compared to ticagrelor. So this patient needs to be treated with other molecules. So what are these other molecules? So when we compare or when we see other two antiplatelet like clopidogrel and prasugrel, we see a major difference is that as compared to clopidogrel or prasugrel is an active molecule which doesn't require any conversion from product to active molecule. So itself is an active molecule and it binds reversibly to P2 vital ADP receptors, although the different site of action is there. And half-life is concerned, almost these drugs are on almost similar half-life. So it's known how pharmacology or chemical class can modify your clinical efficacy as well as safety. So, from physical perspective, which is the right oral antiplatelet in this scenario? So the data says that ticagrelor or Brilinta is clinically superior compared to the clopidogrel or prasugrel in reducing the cardiovascular death, repeat MI, as well as all-cause death. Last decade or recently, few years back, this TIMI-38 trial was there, which shown that prasugrel has a lesser cardiovascular outcome or less stent thrombosis as compared to ticagrelor, but this comes at the risk of increased fatal bleeding. This is the data which compares prasugrel versus clopidogrel, and it clearly shows that although the beneficial effects of prasugrel are there, but it comes at the cost of increased bleeding. So prasugrel should not be given in patients patients who are underweight, less than 60 kg. It should not be given in patients more than 75 years, or should be given with the reduced doses. And it is contraindicated in patients with stroke or TIA, and is CABG done at least 7 days after the 7 days. So these are the certain limitations of using the prasugrel. So the data about the ticagrelor uses is clearly mentions that this is the landmark trial that's Plato, which came in 2009, and Pegasus trial, which came in 2015. It shows that the uses of ticagrelor in ACS patients up to 1 year, that is 90 milligram twice a day, and beyond, that is 60 milligram twice a day, in patients with having high ischemic risk, shown to have reduced cardiovascular death, MI, or stroke at 1 or 3 years of follow-up. So this data shows that the clopidogrel versus ticagrelor composite cardiovascular death after 1 month is less with the ticagrelor. Similar data is seen after 1 year of follow-up. As far as bleeding side effects are concerned, ticagrelor has been shown not to increase the risk of fatal bleeding over the clopidogrel up to 1 year. So reduction in cardiovascular death observed with ticagrelor versus clopidogrel irrespective of the treatment strategy. So when comes the role of ticagrelor after angioplasty, it is most important from the cardiologist to reduce the risk of stent thrombosis, or patient should not come back to your hospital again with a chest pain like in this case. So for that reason, stent thrombosis needs to be managed, to prevent stent thrombosis. Cardiologist or a physician should be comfortable in prescribing the best possible option that we have, that is ticagrelor or Brilinta. So ticagrelor has shown that the risk of stent thrombosis is definitely less while using the ticagrelor as compared to clopidogrel. And this risk of reduction of stent thrombosis within 30 days or up to 1 year is consistently seen with the use of ticagrelor on 90 milligram twice a day. And comparison, if you see the data, there are a lot of trials which shows a comparison between the clopidogrel and ticagrelor, irrespective of their status, whether ACS like in STEMI or non-STEMI. The data favors the use of ticagrelor in reducing the risk of stent thrombosis. So ticagrelor has shown that 49% reduction in definite stent thrombosis. This is basically a single center trial from the real world patients. So if you have been convinced for using ticagrelor, then what is the exact duration up to which ticagrelor should be used? We know that use of ticagrelor up to 1 month has significantly shown to reduce the risk of absolute as well as relative stent thrombosis. But this data, like Plato, has shown that the consistent results are seen when the patient is given up to 1 year of aspirin with ticagrelor. And we can say by the end of 1 year, there is 16% relative risk and 19%, 1.9 absolute risk reduction is seen at the 360 days. And as I spoke, the Pegasus trial has shown that in patients with high thrombotic or high ischemic risk, patients should continue prolonged use of ticagrelor up to 3 years. And in that patient has shown to have less CV mortality, but obviously it comes at the risk of increased bleeding. So this is the Pegasus trial, which shows that use of placebo versus aspirin, placebo with aspirin versus ticagrelor. Use of ticagrelor has lesser cardiovascular death or MI, but it increases the major bleeding in patients who are on prolonged DAPT with the ticagrelor. So the physician or practitioner may ask, so do we need to give ticagrelor in all patients? No, it's not indicated in all patients. Prolonged duration is not indicated in all patients. So patients who are having high ischemic burden, like patients who are having MI within 2 years, like in this patient, in this case, a patient having a recent MI, or a patient having multivessel coronary disease, if patient is having diabetes, or patient having CKD, peripheral artery disease, or having history of multiple prior MI. So in this case, we need to give extended doses of ticagrelor beyond 1 year. So as I spoke, presence of 2 or more risk factor increases and prolong the ischemic risk. So these patients like CKD, multivessel disease, diabetic patient, peripheral artery disease, such patients should be given ticagrelor 60 milligram twice a day beyond 1 year up to 3 years. And this shown that 34% relative risk reduction in cardiovascular mortality. So choosing between the ticagrelor brands now comes to the brands. We know that we are using ticagrelor in patients of high ischemic burden up to 1 year, even beyond that in certain cases. So which molecule is preferred? So there are a lot many generic molecule available in India, but as this slide says that the pharmaceutical equivalence, that is stability and resolution of testing, may not be equivalent to the blood concentration of a drug in healthy volunteers. Thus, it may not be equivalent to the bioequivalence. And the bioequivalence may not translate into the therapeutic equivalence, so which actually affects the outcome in patients. So every ticagrelor molecule may not be equivalent to the innovator brand, that is Brilinta. So we can see that the 45% of range variation in bioavailability might lead to differences in outcome in acute coronary syndrome patient. For example, decrease in the bioavailability of oral antiplatelet obviously will reduce the platelet inhibition and will increase the risk of ischemic event. Similarly, increased bioavailability increases the platelet inhibition and increase the chances of or risk of bleeding. Because we know that the ticagrelor itself has a 6 chiral center and has a 64 possible stereoisomer. So having the right stereoisomer is key for reversible inhibition of platelets. So all generic brand may not have the isomeric purity as the innovator molecule. This study from the Kerala has shown that the range of variation in actual ingredient between the different brands or different generic molecules. So these differences in purity and viability in genetics really lead to differences in the clinical outcome, in the impact of efficacy as well as patient's safety. So this use of generic brand, which may not be as equivalent to the innovator molecule, and this has already been studied in the Mount Sinai, New York, where the generic clopidogrel has shown to increase the 2.74 risk of definite stage thrombosis compared to the innovator molecules. So the data doesn't support the data doesn't support the use for the molecules because they may not be as pharmacologically pure as the innovator molecule. So that this says that the innovator molecule, like in this case AstraZeneca, which has robust data, be it these have a large number of randomized controlled trials like Plateau, Pegasus, Atlantic, and almost 1 lakh patients have been studied. So Brilinta as an innovator molecule has approved in more than 100 countries. So we have the data, we have the evidence. So obviously, whenever the possible in high risk patients, innovator ticagrelor should be preferred. That is, Brilinta should be preferred. So ticagrelor is the only P2Y12 inhibitor which decreases the cardiac mortality significantly in ACS patient and is indicated to provide the 48 months protection in post-ACS, post-PCI cases. As we noted, the bioequivalence may not be transferred to therapeutic equivalence. So all molecules may not, or all generic may not be as equivalent to as Brilinta, and it may affect the safety and efficacy in patients' management. Thank you.
So, thank you very much, sir. Yeah, yes. Yeah. Dr. Meenakshi Deshpande, madam. Sir, your lecture was very excellent, and you have shown the few slides with valuable data, so that we can know that ticagrelor is very much effective and it is safe also. So
yes,
when you do all these MI procedures like angioplasty and all, so when you use stent, it is you are also confident that patient will have a less morbidity and mortality. So thanks to our modern medicine. So, and thanks to you also. So I request our president, madam, to felicitate you. So
I'm having an Uparna. So thank you very much. This is a Uparna from me.
Yeah.
Thank you, madam.
Yeah. And that was a wonderful speech. It was a beginning of a good, I mean, you have made a good stand for the other talks after this. So that is a good start to a good program today, webinar. Thank you so much.
Thank you. Thank you.
Okay. Virtual. Okay. Yes, sir.
Okay.
Thank you. Thank you. Can we go to the next lecture? It is by Dr. Manoj Durairaj on role of dapagliflozin in patients with heart failure. Dr. Manoj Durairaj, I will just introduce in a very short, because he is all our speakers today they are very eminent, and if I start giving their introduction, I think all 3 hours will be in the webinar will be in the introduction. So Dr. Manoj Durairaj is a MS gold medal from Pune University. He is a MCH, AIMS, New Delhi, FACC fellowship, fellow of American College of Cardiology, adult and pediatric heart surgeon, heart transplant surgeon, junior vice president, Indian Association of Cardiothoracic Surgeons, executive member, Society for Heart Failure and Transplantation, founder, editor, the Revival newsletter of the SFHFT, 21 publications in cardiac surgery, including book chapter in international index journals, awarded Outstanding Citizen of Pune by Mayor Mukta Tilak for starting heart transplant surgery program in Pune. So over to you, sir. Thank you and welcome, sir. We can start, sir.
Yeah, thank you, madam. And I hope I'm audible, madam.
Yes, sir. Yes, sir.
Yeah, I thank the IMA Pune at the outset, President Madam Deshpande Madam, and all the organizers of this symposium. and also AstraZeneca for having me over and giving this talk. This is a very interesting molecule, SGLT2 inhibitors. There are two molecules of very great importance in this class, which is the empagliflozin and the dapagliflozin. And this has basically revolutionized the management of heart failure with reduced ejection fraction, moderately reduced ejection fraction, and preserved ejection fraction. Studies have already come out with empagliflozin and preserved ejection fraction. Dapagliflozin studies are on, and some of them have been completed. And I will actually show you the evidence that this molecule is basically a blockbuster in the scenario of heart failure. Now, when you look at heart failure, there is a cohort from Trivandrum called the Trivandrum Heart Failure Cohort or Heart Failure Group, which was started around 8 years back by Professor Hari Krishnan from Sri Chitra, and they have found that 70% of patients in heart failure are because of ischemic cardiomyopathy. And if you look at the worldwide estimates, around 64 million people have got heart failure as early as 2016. So the numbers would have definitely grown up. Now, from the index admission of heart failure, there is a chance of 22% mortality in the first year for these patients. So the survival is worse than a patient having prostate cancer in men and worse than breast cancer in women. So why does this happen? Because the heart failure awareness so far has not taken off. And through this symposium, we have a feeling that maybe we should make people more aware that heart failure has got a high morbidity, mortality, and we need to be very, very aggressive in our medical management. Now, the mortality improvements have been seen in other major cardiovascular disease, like, for example, angiography, angioplasties during bypass surgery. So, atherosclerosis, yes, but the advances has not been seen in patients with heart failure or arrhythmia in even developed countries like US. So, we are looking at India from a different perspective. So, there are only 18 to maybe 8 to 10% of patients, maximum around 15% of patients who are actually following guideline directed medical therapy. The guideline directed medical therapy as of date includes an ARNI, it should include an MRA, it should include a beta blocker, and also an SGLT2 inhibitor. When you look at the target achievement in US itself, it is just 1.5% to around maximum 18 to 22% of different molecules. But when you look at the guideline directed medical therapy, which I'll show you later, which all of us need to be aware of, that there are 4 pillars of heart failure, which I will talk to you, including a 5th pillar. We have to be sure that our heart failure patients are receiving that, so that from this maybe 8 to 10%, we can get around 80 to 90% compliance from our side. Now, what about dapagliflozin? Dapagliflozin was studied extensively in DAPA-HF trial, and basically this correlated what is the molecule and whether it can prevent adverse outcomes in heart failure. So it was called dapagliflozin and prevention of adverse outcomes in heart failure trial. So DAPA-HF trial. The DAPA-HF trial assessed the safety and efficacy of the dapagliflozin in patients with established heart failure with reduced ejection fraction, with diabetes mellitus and without type 2 diabetes mellitus. Now, many of you will wonder, this molecule is basically for hypoglycemia. Why are we using it for patients without sugar issues? The answer will be known to you very, very shortly. So 4,744 patients were recruited. All were more than 18 years of age, with or without type 2 diabetes mellitus. This is very, very important. And the diagnosis of symptomatic heart failure was done, which was more than 2 months. LV ejection fraction was less than 40%. That means reduced ejection fraction. All the patients had evidence, biochemical marker NT-proBNP was done for all these patients, which was established that they have ongoing heart failure. And all these patients had stable standard of care, which was already done for heart failure. So dapagliflozin 10 mg was given with, in addition to the standard of care. In the other wing, placebo was given with the standard of care. And this was the visitation points up to quite a few months, almost around 1.5 years. And the primary endpoint was time to first occurrence of any component of the composite, whether it was cardiovascular death or hospitalization due to heart failure or any urgent heart failure visit, maybe even to the OPD. The second endpoints were time between the cardiovascular death and hospitalization for heart failure, and also symptomatology, whether the quality of life had improved for these patients. And very, very important, whether these patients succumbed to end stage renal disease or whether the EGFR was declining very, very, very badly. This was also noted. And the time to death due to any cause was noted in the study. So what happened? When you look at the demographics, this was ages was 66 years, 76% were male, mean ejection fraction was around 31%, and the NT-proBNP was raised. Many of these patients, like our real world scenario, many of these patients had atrial fibrillation because of LA dilatation. They had already history of heart failure, hospitalization, and look at this: 45% of these patients were diabetic. That means 55% of these patients were non-diabetic group in the heart failure with reduced ejection fraction. So what was the study outcomes? They found that the relative risk reduction of cardiovascular death or worsening of heart failure. Now, this is a new term, worsening heart failure, because you have a patient stable on heart failure, you're giving all the treatment, they can actually dip. That term is called WHF, worsening heart failure patients. So there is 26% relative risk reduction when you compare head to head by introducing DAPA, gliflozin, to this standard of care. That means just introducing this molecule can reduce your cardiovascular death and heart failure hospitalization by almost 30%. So this was statistically significant, not like within 3 months, 6 months. This primary endpoint of cardiovascular death reduction, hospitalization for heart failure reduction, was seen as early as 28 days. That means the molecule is working so powerfully in this group of patients who are very, very sick. And there are studies showing in cardiac MRI, in echo, that the LV volume end systolic volume index, the LV end diastolic volume index comes down dramatically by almost 20% within 1 month once you start this molecule. And actually, it starts improving by 3 months, 6 months, and 12 months. So the benefit of DAPA on cardiovascular death and worsening heart failure was significant starting from day 28. This is very, very important. That is why we are emphasizing that this molecule should be started as a hospital discharge molecule. It should not be started on OPD after the patient comes. No, if the patient is admitted for heart failure, as soon as you can start the molecule. Now, individual components like worsening heart failure, there is a 30% relative risk reduction. Cardiovascular death, there is around 20% relative risk reduction, and this carries on for more than 2 years also. So this is the basic outcome: cardiovascular death reduction, urgent heart failure visit, hospitalization for heart failure, or death due to any cause. And you'll find that DAPA, basically, the weightage is more as compared to the standard of care with a placebo. So when you look at introducing this molecule, all these outcomes, beneficial outcomes, are there. The same thing. Now, if you look at the categorization of the patients, whether it was in different subgroups, I will look at the subgroup where the patient does not have diabetes. Now, if you look at the subgroup as compared to placebo, the overall effect is much better in this group. So if you look at that group, you'll find that the event rate is much lesser. That means the number of patients having events is much lesser as compared to placebo, even better than a diabetic patient. And you can consider the other groups also. Patient had sacubitril valsartan. This molecule actually reduces the death rate and the cardiovascular death rate and hospitalization when it's added to the molecule. And atrial fibrillation, NT-proBNP, poor ejection fraction, NYHA class, through all the subset, this molecule works very well. And we are interested in our Asian subset. So around 18 to 20% of the population was belonging to the Indian subcontinent, that is the Asian subcontinent. And this molecule was very, very efficient in the Indian and the Asian ethnicity, what we call. So DAPA performed better in our Asian population too. And many of these study sites were in India and in Asia, and they found that in Asia also this molecule works very well. And we will also be very, very keen to know that. And the other group is ischemic or non-ischemic. So in both the groups we can use. I use this for dilated cardiomyopathy patients also. Any patient with heart failure which is reduced ejection fraction, I go ahead 100% with this molecule. And same thing in type 2 diabetes mellitus, you have normoglycemic or pre-diabetic patients. All these patients, you can use this molecule. Don't be scared of hypoglycemic events. It just does not cause. And then if you look at the secondary endpoints, whether the first hospitalization for heart failure or cardiovascular death, or total hospitalization for heart failure, cardiovascular death, you'll find that using this molecule, you'll have a 25% relative risk reduction. Now, I won't go into this too much in detail, but the gist is that when you introduce a molecule like this, the quality of life improves. The numbers may not rise. Like, for example, if you have an ejection fraction of 25%, it may improve to 30%. But a patient who was not able to walk one flight of stairs will say, trust me, I have patients like that who can walk actually 2 flights of stairs with a poor EF. You can't believe it. You need to use this molecule to believe that. So what we call is quality of life actually improves with this molecule. So simple things like going to the washroom, doing little bit of walking, going outside is becoming laborious for these patients. But introducing some molecules like ARNI and SGLT2 inhibitors actually changes the game. This is the same thing. It's a busy slide, but trust me, we are looking at quality of life, and this is not only seen in like 2 weeks, 3 weeks. It is seen within the first 1 month, and then it carries on till the time the patient is taking the treatment. Some of these patients have actually withdrawn the tablet for some reason. It was here, not there, whatever, or they had gone out of town. They said that the quality of life actually drops when they stop the molecule. So they keep calling me and saying, doctor, somehow or the other, this molecule has to be in my prescription. See that it is not without this molecule. And when you look at the worsening renal function, it is a problem for us. How do we maintain the kidney function for a patient with low cardiac output? So a patient is having a cardiorenal syndrome. Using this molecule, what happens is the cardiac output improves, the renal perfusion improves, the lot of intra-abdominal pressure issues improve because you can improve the heart function as well as the kidney function, and there is a reduction in the eGFR slope. So there's the decline in eGFR slope rather than going down for a heart failure patient. Actually, it becomes more stable, and the patients who can be pushed into end-stage renal disease or renal deaths, actually the numbers come down dramatically by using this molecule. So there is a more than 50% improvement actually in the renal function and the chances of this patient having a renal death. And also, now the secondary all-cause death is also reduced by using this molecule by 17%. So this tablet, basically, you'll understand, is really a blockbuster molecule. There's no doubt about it. And then when you look at patients with new onset type 2 diabetes mellitus, now you'll find that in patients with heart failure, no diabetes mellitus at all, the patient can develop new onset diabetes mellitus, maybe because of a lot of maybe pancreatic ischemia. We don't know what the basic pathophysiology is, but this molecule reduces the chances of new onset type 2 diabetes mellitus in this particular subset of patients. So that is also very important for us to understand. Almost 32% relative risk reduction. There are adverse side effects. Of course, every molecule has an effect. This dapagliflozin binds to the SGLT2 receptor. It inhibits it. Hence, there is glucosuria. Because of glucosuria, we have to counsel the patient that they have to keep a close watch on genital hygiene, which is very important. So especially ladies, we have to counsel them. There is chances of urinary tract infection. So we have to be very, very, need to spend a little more time with them. And there are molecules where we have to actually withdraw the molecule because of genital urinary infection. Keep a close watch on that. I will not say that this molecule does not have patients without urinary tract infection. I have seen patients at that point of time, you have to be very cautious and withdraw. There's also a chance of hyperkalemia, especially when you add it with an MRA at the baseline. So that also something which we need to be concerned. So what I do is I see that the patient initially when I'm starting the molecule, we do serum electrolytes every week along with renal functions with EGFR. So every week you get it done. Once a patient is stable, then you can do these tests every month. Same thing. So other thing, some people will be, scared. What happens to hypoglycemia by giving this glucosuric kind of drug to a patient without type 2 diabetes mellitus? When you look at major episodes of hypoglycemia, it is negligible as compared to a patient with, diabetes mellitus. So actually, there are no hypoglycemic events in a patient with without diabetes. Actual hypoglycemia has happened in a patient with diabetes mellitus, maybe with other OHs also on board. They might be having other OHs. So major hypoglycemia was seen in the diabetes group. Hypoglycemia was not seen in the non-diabetic group. Same thing, I won't go into the details. There are multiple things. So the summary of this trial was, this was the first and only SGLT2 inhibitor demonstrating a reduction in cardiovascular death, all-cause mortality, and hospitalization to heart failure in both patients with diabetes and patients without diabetes with reduced ejection fraction. And this is the numbers. Now, when you look at the Emperor Reduced trial, they found that it was a second, I won't go into these details due to paucity of time, but then again, there was definite improvement in the cardiovascular outcome. Now, there are many trials which are going on, which are there, like the DAPA-HF trial, which was the first trial to demonstrate that SGLT2 inhibitors reduce cardiovascular death, all-cause mortality, and hospitalization to heart failure. Then there is a declared TIMI 58 trial, which basically is prevention, and the DAPA CKD trial, which was there to prevent the patients from declining, the renal function from declining. So all these trials are basically to tell us that this molecule can be used in the whole spectrum of cardiometabolic and cardiorenal patients. So we can go ahead with these patients at any point of time. Now, empagliflozin, there's already trials which is there for preserved ejection fraction. That means heart failure with patients with ejection fraction more than 50%. That is already established. So empagliflozin has already been established. Dapagliflozin, this trial basically is it's June 2022. That means last month it was completed. So the numbers and the outcome is not with us at the moment. But basically, this delivered trial, which will tell us whether DAPA can be used for patients with preserved ejection fraction. So there are multiple trials with dapagliflozin. We have no doubt that this molecule works for heart failure with reduced ejection fraction. This molecule, whether it's working for preserved ejection fraction, acute heart failure, acute MI, is all these trials are going on, like Determine, Deliver, Determine Preserve, DAPA Act HF, DAPA MI. So all these trials are going on and we are eagerly waiting for the outcome. Now, how do you implement DAPA in your clinical practice is the question. So there is a rapid sequencing, what we call by McMurray. We established that the patient has got heart failure. You can do a 2D echo to check that the patient has got a reduced ejection fraction. So what we need to understand is first decongest the patient and initiate guideline-directed medical therapy. The 4 pillars of heart failure you need to know are ARNI, beta blocker, MRA, and SGLT2 inhibitors. These are the 4 pillars. The 5th pillar, according to me, is iron injection. That means iron supplementation. This is very important for heart failure. We have to estimate the iron ferritin ratio. We need to understand what is the iron deficiency and correct it as soon as possible. So I'm deviating from the talk, I'm sorry, but the recommendation for SGLT2 inhibitor is class 1A recommendation. That means the recommendation level and the level of evidence is 1A for patient with symptomatic chronic heart failure with reduced ejection fraction. SGLT2 inhibitors have to be given to reduce the hospitalization for heart failure and cardiovascular mortality, irrespective of the presence of diabetes mellitus. So there is no doubt we have to use the molecule. Same thing, same slide, but it's a different guideline altogether. So what would you do? So how would you sequence it? Now, this is again deviation from the talk. The main thing is we are looking at the pharmacotherapy. We are not looking at CRTP and other things. So if you look at the European Society of Heart Failure guidelines, these definitely say, if you look at this row here, DAPA and EMPA are recommended for patients with heart failure reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. This is a class 1A indication. So this is what I was telling you about. And then obviously you need to, there are a lot of things about the visitations and other things. And the same thing here. Now, how do you, the rapid initiation is very important. So you have a patient coming in with heart failure. How will you initiate? What are the drugs to be given? The first drug in my treatment is using an SGLT2 inhibitor. DAPA or EMPA definitely goes in immediately. Why does it go in? Because it is dose specific. You need to have only 10 mg on board. You can give it in the afternoon. You can give it after food, no problem at all. You don't have to worry about blood pressure. You don't have to worry about the renal function deteriorating. You don't have to worry about the hepatic dysfunction. You can just give this molecule. Along with that, you can introduce a beta blocker. The beta blockers I would prefer. If a patient is hypertensive, then use carvedilol. If the patient is, the pressures are a little bit borderline, you can use the bisoprolol, different molecules. You can use nebivolol. And if sometimes, if the heart rate is little, the blood pressures are on the 90s, then you can even use ivabradine. Step 2, that means within 1 or 2 weeks, you start introducing ARNI. And after that, you start introducing your MRA. It can be eplerenone or aldactone. So this is called rapid sequencing. And the person who has actually, the name behind that is McMurray. McMurray published this in Circulation 2021. So I won't go into all these details. I'm happy to use the question answer time to answer the questions. So patient selection, when you use it, you can consider using for all heart failure patients with reduced ejection fraction. Dosage 10 mg once a day. The pre-initiation consideration, you need to see the patient is euvolemic. You can't have a patient who's dehydrated. Renal function, definitely assess it. And the prescription, just watch, because there will be osmotic diuresis in these patients. So you need to watch for volume depletion. Reduce the diuretic dose. When you have this patient on dapagliflozin, reduce the diuretic dose, because the diuretic requirement will come down. Symptoms of ketoacidosis need to be looked at. Symptoms of genital infection also need to be looked at, and we need to recommend genital and perineal hygiene. And also the follow-up is very important. So we ensure that the patient regularly takes his blood pressure, even at home. A weekly follow-up in the first 1 month. You do the renal function test, do the sugars, do the electrolytes. This is very, very important. And keep asking the patients for symptoms and signs of urinary tract infection. I hope I have finished on time. Thank you very much. Over to the chair, please.
Yes, sir. Thank you very much, sir. You have elaborated all the use of dapagliflozin and comparing with empagliflozin also. Both the drugs are really effective, and they are doing wonders in your heart failure patients. So thanks to our researchers and the people who are getting this medicine, and after the trial, we are seeing that effect is there. So it is a real boon for our heart failure patients. So thank you very much, sir. I request our President, Madam, Dr. Meenakshi Deshpande, to felicitate you. And this is a bouquet to you, sir. Virtual bouquet, sir.
I
Please
accepted
come to
it.
IMA anytime, sir. Thank you, sir.
AstraZeneca has made it so virtual, and all the webinars are equally good.
Yeah.
So it's very nice to hear all the faculties giving good lectures, and good topics are really handled very well by you all. So welcome to IMA Pune also whenever it's possible for you.
Sure, madam. Sure.
Yeah, this is a Uparna from my side.
Thank you, madam. Thank you.
Yeah, from IMA.
Thank you, madam.
I hope it comes in the screen.
Yeah.
Yeah.
Yes, sir. Sir, it is here.
Yeah, okay, madam. I've
Yeah,
received it.
about 2 will be having.
Yes, sir.
I've received it.
Yeah, okay.
Thank
Fine,
you.
fine,
Very much, sir.
Thank you.
Thank you very much.
fine.
Bye.
Yeah.
Bye.
Thank you.
Now we'll be going to the third speech. It is by Dr. Sudhir Zavade, role of dapagliflozin in addressing the cardiorenal and mortality burden with CKD. Sir also needs no introduction, but still I will introduce sir. Sir, you are joined.
I'm trying to.
Yes, sir. Sir, you can. Yeah, we can hear you.
I cannot start my video, but
Yeah,
just see.
You can take time, sir.
I think my video is not working, so I will just share my screen. If
Okay, sir. Try to share the screen.
I think you can see the screen now.
Yes, sir. Yes, sir. Yes, sir. We can.
Yeah.
Sir, I will introduce you in short. Sir is a DM nephrology. Is a consultant nephrologist at Pune Hospital and Research Center, Jahangir Hospital, Sahyadri Hospital, Inamdar Hospital, and Noble Hospital. He is an assistant professor nephrology at Bharti Hospital and Research Center, Bharti Vidyapit, Katras, Pune, and he's in charge of dialysis center, Pushpa Devi Dugat Charitable Dialysis Center, Gangadham Chowk, Pune. He has worked in Nair Hospital, and that is TN Medical College, and Kashibai Navale Medical College and Hospital, and BJ Medical College and Sassoon Hospital also. He has got many publications and research papers nationally and internationally. So I think with this short introduction, all the speakers today have many pages introduction, but I am just introducing in very short due to lack of time. So over to sir. Sir, you can start, sir.
Yeah, good afternoon. Sorry, I cannot start my video. So
Okay,
there's some problem with the video. So I think the topic which
Slides
has
are
been,
very well seen, Dr. Javle, so you can actually continue.
yeah.
The
So
video is after this, or?
no, my this webcam is not acting. So it's okay. Yeah. So like I will be discussing about role of dapagliflozin in addressing the cardiorenal morbidity and mortality burden with the chronic kidney disease. So as we know, this chronic kidney disease have been increasing as the days are progressing. It impacts around 1 in 9 people globally, and around 2.6 million people over the around the world are receiving renal replacement therapy, and it accounts to around 1.2 million deaths annually. So, and it has been predicted that by 2030, there will be more than 5 million people will requiring renal replacement therapy. It is probably by the population aging and the increased prevalence of diabetes and hypertension. So definitely diabetes and diabetic kidney disease has become an important part of our nephrology practice. If there has been several studies which have tried to find out the etiology in chronic kidney disease over the different over the world, or even in India, we have a study. It accounts to more than 30 to 35% of total CKD populations have diabetic or diabetic kidney disease. And we most of the developed nations spend over 2.2 to 3% of their annual budget on chronic kidney disease treatment. So whatever studies have been done, or whatever advances has been done, it has been shown that there is an improvement in CKD mortality has been limited, but the RRT burden has continued to rise. So we need to stop. The importance of this statement would be we have to find out ways so that we can be able to retard the progression of the chronic kidney disease, so that we can delay the chronic kidney disease patients to go on for renal replacement therapies. So this is in this talk we'll be talking about one molecule which probably helps us in that direction. So and another important point about CKD progression is, as the CKD progresses from stage 1 to 5, there is a higher risk of morbidity and mortality. Say whether it is hospitalization, whether there are cardiovascular events, or even death from any cause, all increases as the patient the GFR goes below 15, and when the patient leads to renal replacement therapy. Even non-atherosclerotic heart diseases like LVH, arrhythmias, sudden cardiac deaths, the arterial calcification, cerebrovascular accidents are increasing as the chronic kidney disease progression. And the risk of mortality, it doesn't depends only on diabetes. It is basically the associated with the GFR. So as the patient goes for a chronic kidney disease stage 5 and the GFR goes below 15, the risk of mortality increases. And the important cause, the leading causes of death in chronic kidney disease are usually cardiovascular diseases or infections basically. There have been several studies which have been done in past, renal outcome studies, which have, but in those maximum of these studies have included type 2 diabetes patients as their primary patients. But over the years, whatever trials we had or whatever say, only 2 drugs which have been given us a good in our armamentarium to see decrease the progression of chronic kidney disease has been only ACE inhibitors and ARBs. So there have been number of trials which have proved that ACE inhibitors and ARBs are good and which decreases the progression of chronic kidney disease. There have been certain studies which have tried to combine ACE inhibitors and ARBs, but ultimately it led to hyperkalemias, deaths, and hospitalization. So those studies have to be stopped early. There was another drugs called as bardoxolone beacon trial, which have given a ray of hope that it was only a drug which has shown to have increase in the GFR. Other drugs retards the progression. This drug had shown increase in GFR, but unfortunately these patients had, there were so many cardiovascular events in that particular trial that it had to be prematurely stopped. So till now we had only angiotensin converting enzyme inhibitors and angiotensin receptor blockers. These are the 2 group of drugs which we could use for management of chronic kidney disease progression, and this has been for nearly 20 years. So you can see over the years there were so many trials, but we didn't have any other medicine which could help us. So now that we have an SGLT2 inhibitors, so how does basically this SGLT2 inhibitor acts? What is SGLT2 inhibitor is basically present in the proximal convoluted tubule. It blocks the proximal glucose and sodium reabsorption. So what will happen? It will deliver this sodium to the distal the loop of Henle, and when it comes to the macula densa, there will be a feedback, tubuloglomerular feedback will be restored, and hence there will be a decrease in the glomerular filtration and hydrostatic pressure. Why we want to talk about this glomerular hyperfiltration? And that is how the chronic kidney disease in diabetes happens. The first and foremost, the event which happens in diabetes leading to diabetic kidney disease is the glomerular hyperfiltration and increase in the hydrostatic pressure in the glomerulus, which will eventually leads to increase in proteinuria, and finally it leads to increase in the creatinine. Other than this, there has been other downstream effects like decrease in the urinary albumin excretion, which will decrease the pro-inflammatory pathway activation, and also it inhibits the direct tubular toxicity. At the same time, there is improved cardiac function and increased hematocrit concentration, which helps in results in a increased oxygen delivery to the kidneys and improvement in the renal hypoxia. So the SGLT2 inhibitors acts through multiple pathways, which helps in decreasing, which has got its beneficial effects on the renal function. Usually this heart and kidney are most of the times it is interconnected, and if you see this particular drugs has both cardiac and renal protection. So how does it happens? Basically, as we have seen it in kidneys, it leads to glycosuria, diuresis, and natriuresis. So all this will lead to decrease in plasma volume, decrease in the arterial stiffness, and it also helps in some amount with the decrease in the systolic blood pressure. So this will help in decreasing in preload, the cardiac wall stress, and it increases the cardiac efficiency. So finally, there will be improvement in both the cardiac and renal functions, and will we have a good clinical outcomes like decrease in cardiovascular events, decrease in heart failure, hospitalization. We will have stabilization of EGFR and decrease in the albuminuria. So there was this one trial declare which demonstrated around 47% relative risk reduction in the occurrence of renal specific composite outcomes. Here the dapagliflozin did much better than placebos, and around 80% of patients had background use of RAS inhibitors. And this reduction was demonstrated across the all clinical important components of the renal specific composites like end stage renal disease and renal death. So what we will discuss is about DAPA CKD trial. This was a landmark trial which assessed dapagliflozin in more than 4,000 patients. So this number was very important because it has a huge number of patients with chronic kidney disease which were included in this particular trial. And in this particular trial, they had both diabetic as well as non-diabetic patients. And they included up to the patient with GFR of up to 25 and proteinuria from 200 to 5,000 milligram per gram. Maximum, all patients were on maximum tolerated doses of ACE inhibitors or ARBs for more than 4 weeks. They were divided between dapagliflozin and placebos. So if you see, the maximum number of patients were diabetic nephropathy, but there were still many patients who were having glomerulonephritis. There were quite a few number of patients who were having ischemic or hypertensive nephropathy. Similarly, this is the etiology of CKD. If you see, there was in the patients who had non-diabetic, had around 34% patients had ischemic or hypertensive nephropathy. Around 42% patients had chronic glomerulonephritis. This is important because in these set of patients also, we have only ACE inhibitors or ARB. Dapagliflozin, if we say it comes as a anti-diabetic drug, but the use of dapagliflozin in chronic glomerulonephritis is a huge benefit for this particular molecule. So it slowed the, in DAPA CKD, it has been showed that it has 39% relative risk reduction in the risk of adverse events like sustained more than 50% GFR decline, end-stage kidney disease, and renal or cardiovascular deaths. And treatment benefit was consistent across the pre-specified drugs, whether it was type 2 diabetes at baseline or no, whether there was a GFR, whether it was less than 45 or more than 45, and all sets of CKD stages from stage 2 to stage 4. In this forest plot, all markers are in the favor of dapagliflozin. And it was determined whether there was male or female in all types of geographic regions. This drug has shown wonderful results. It demonstrated a significant reduction in death from any cause. There was 31% relative risk reduction in all cause mortality. So this is also very important, which included both cardiovascular and non-cardiovascular deaths. There was a decrease in, there was 29% relative risk reduction in patients with, in these patients with leading to cardiovascular death or hospitalization with heart failure, which was consistent with previous dapagliflozin, the trial which Dr. Dureraj sir talked about, DAPA heart failure. There was statistically significant treatment benefit in all primary and secondary outcomes. The primary outcomes of this was composite of more than 50% eGFR decline, end-stage kidney disease, and renal or cardiovascular deaths. Secondary outcomes were all-cause mortality and composite of cardiovascular death and hospitalization, or composite of more than 50% eGFR decline, end-stage kidney disease, or renal death. So it was the benefit was through whether all types of kidney disease, whether it was a diabetic nephropathy or ischemic or hypertensive CKDs, or whether there was primary glomerulonephritis. So all these patients had shown a better results, whether it was associated with heart failure related hospitalization, whether it was cardiovascular death, all-cause mortality, or renal specific outcomes. So primary outcomes by diabetes status, if you see, even patients who were with non-diabetic, there was also 50% relative risk reduction in the GFR decline, end-stage kidney disease, and renal or cardiovascular deaths. When you take together, there also there was 49% and 43% relative risk reduction with this particular molecule. All-cause mortality, again, even if you divide between diabetic and non-diabetic, there was significant relative risk reduction. So definitely this drug has given us a very good alternative to help in decreasing the renal and cardiovascular events. So this was another subgroup analysis where they had a pooled analysis of DAPA CKD and DAPA heart failure patients. This was a where the patients who didn't have diabetes at the baseline and explore the effect of dapagliflozin on incident type 2 diabetes during this particular trials. So it was seen that dapagliflozin reduced the relative risk of new onset diabetes by around 35%. 33% in patients without diabetes at baseline. So this was another plus point for this particular molecule. It reduced the risk of AKI is also, this was very surprising. Initially, if we see DAPA, when you start dapagliflozin, there is a slight decline in GFR. That is because initial part there is a, it goes down, but later on it picks up and it stabilizes at certain point. So this was another important point about that, it reduced the risk of acute kidney injury versus placebo. When we talk about safety profile, again, there was not much of difference between the placebo and dapagliflozin. When we talk about major hypoglycemias, it was only 14 patients in DAPA and whereas 28 patients in placebos. So there was not much of difference. Volume depletions was definitely high. As sir said, there is a patient because of glycosuria and natriuresis, you tend to have good amount of water loss. So patients need, all the patients who are being put on dapagliflozin should be asked to take sufficient amounts of fluid and keep a genital hygiene. There was another group set of patients in DAPA CKD of IgA nephropathy. This is the glomerulonephritis. If you see the first table, the number of participants with IgA nephropathy, which in basic stop IgA, there was a landmark trial in IgA nephropathy, stop IgA. There was only 162 patients, but in patients in this particular study of DAPA CKD, we had 270 patients. So definitely the evidence is pretty strong in this DAPA CKD in patients with IgA nephropathy. And again, here we can see that primary outcomes in participants with dapagliflozin has definitely much, hazard ratio was much in favor of dapagliflozin, whether it was a primary endpoints or kidney specific endpoints or the composite endpoint of chronic kidney disease, chronic dialysis or renal transplant or renal death. So in IgA nephropathy, which is a non-diabetic kidney disease, dapagliflozin had shown a good results. So there was a numeric reduction in the relative risk of primary composite endpoints and renal specific composite endpoint with dapagliflozin, as well it was consistent with overall results. And it was well tolerated, and a proportion of patients with serious adverse event did not vary between treatment groups when divided by the underlying cause of CKD. So dapagliflozin has acted equally in a diabetic set of patients and even a non-diabetic chronic glomerulonephritic patient. So this was what, but these are the guidelines which say that SGLT2 inhibitors up to the GFR of 30, it has become a first line therapy. The choice of SGLT2 inhibitors should be prioritized agents with documented kidney and cardiovascular benefits. So this was a KDIGO intervention algorithm, where they have mentioned that all the patients who had increase in CKD risk like diabetic, hypertension, older age, whether there is associated high risk comorbidities, should be screened for chronic kidney disease by serum creatinine or urine albumin creatinine ratio or cystatin C. And if you are we have to identify and treat the specific cause of CKD, find out the albuminuria. Now that chronic kidney disease has been divided into, previously they used to stage 1 to 5, but now albuminuria has also become an important part of that classification. So you have to classify patients according to albuminuria also. And SGLT2 inhibitor is recommended as first line treatment with metformin in type 2 diabetes, and may also have benefits in patients with CKD and no diabetes also. So you have to identify patients and intervene as early as can. So it will help in slow the disease progression, preserves kidney function and reduce complication. So I think, so the global prevalence of and burden of CKD is substantial, driven by diverse etiologies, including diabetes, hypertension, and glomerulonephritis. DAPA CKD was a landmark trial for more than 4,000 CKD patients and with and without type 2 diabetes, which addressed a significant gap in therapeutic innovation, demonstrating a significant reduction in the risk of kidney disease progression, end-stage kidney disease, cardiovascular and renal deaths. And also it helps in relative risk reduction of about 31% in all-cause mortality. There was 29% relative risk reduction in cardiovascular deaths or hospitalization for heart failure. So DAPA CKD builds on the evidence of both DECLARE and DAPA heart failure to further expand the cardiorenal and mortality benefit of dapagliflozin to patients with chronic kidney disease. I think that should be.
Yes, sir. Yes, sir. So thank you very much. Your lecture was very elaborative and very informative. And for the cardiorenal patients, it is a real dapagliflozin is really a wonder drug. So, and for it is for the patient also and for the consultant also. So thank you very much, sir. Sir, here we have our past president, Dr. B.L. Deshmukh, sir. So I will request Dr. B.L. Deshmukh to felicitate you. Sir, you can
Thank you.
share your
My
yeah. So this is IMA Uparna from.
Thank you.
And
IMA bouquet.
Thank you, sir. Thank you. Yeah.
Yes, and this is a bouquet for you, sir.
Thank you. Thank
and
you.
You can visit IMA Pune anytime, whenever you get time.
Sure, ma'am.
Your busy schedule. Huh?
Sure, ma'am. Yeah. Thank you.
Now we will go to the next speaker, Dr. Yatin Zok, sir. He has already joined. Welcome, sir, and good afternoon. Sir will be discussing preventing and managing cardiorenal risk of diabetic dyslipidemia. I will introduce sir. Sir, have you joined, sir? Dr. Yatin Jok, sir. He had joined just now. I think I saw him, sir.
Actually, he joined. Just I will check with him that maybe he has some technical error.
Okay.
Yeah, and just give him 1 minute. I will just check with him over phone.
Even the Deepan sir also can check because he was muted because the voice was coming from his computer. Please wait a minute. Sir is joining. Mr. Deepan sir. Have you unmuted him?
Yeah, hello, ma'am. Just I called him. So just was like power was just down there just for 1 minute. So he will just join. Probably 1-2 minutes he will take and he will join immediately.
Okay, sir.
Yeah,
okay, sir. We will wait for another 1 or 2 minutes.
Yeah.
So he was there and so I said now he can't be visible.
Yeah. He joined actually. The camera and everything was there. He set everything, but just was power. Goes off and he joining just 1-2 minutes.
Yeah. So we'll have a break after 3 topics.
Yeah. Yes, ma'am.
Sir, Dr. Bharat Salve. Dr. Bharat Salve. I think he has also. So in between, I'll take a chance to introduce and about our IMA activities. So on this Sunday, we are having rejuvenating your medical minds at Jagdamba Bhavan, Mundri Pisoli. So it is a free, only the registration you have to do. That registration is compulsory. Then on 15th of August, we are having public awareness program on Stree Shakti. So it will be in Marathi and there will be a very entertaining program for the all public. So you can join that. Sir, you have joined, sir? Sir, I was just waiting. Yeah, let's join. Sir, joining. Yeah.
This meeting is being recorded.
Yeah. Dr. Yatin Jog, sir.
Yes, ma'am.
Yeah. You can join, sir. I'll start with your introduction, sir. सर जरा
शिट यार काय आहे?
आता चालू नाही रे माझं काय चालू आहे. Depends, sir.
Madam, screen is showing some. Hello.
Depend सांगू हा
Hello. सगळं गेलं.
डॉक्टर जोग सर तुम्ही पुन्हा एकदा रिजॉईन व्हा. जोग सर तुम्ही पुन्हा एकदा जॉईन व्हा. बंद करा तुमचं हे आणि पुन्हा एकदा जॉईन व्हा. अनम्यूट करा सर. अनम्यूट युअरसेल्फ. हॅलो. दीपेन सर आवाज येतोय? या गुड. Sir, you can start your presentation, sir. I will introduce you.
Log out केलंय madam.
Maybe.
Okay. Yeah, we told him to log out because the echo was coming and the image was also not proper. So we'll wait for another 2 minutes. Yes, sir.
Yes, madam.
Yes, sir. You can join, sir. No problem. Yeah. Sir, I will introduce you. Dr. Yatin Jog, sir. He is a MD Medicine, consultant physician, diabetologist, internal medicine specialist from Solapur. He is working as consultant diabetologist at Unique Hospital, Solapur. Member of various prestigious medical association and bodies. Areas of interest is diabetology and social awareness. He has delivered number of lectures to various organizations and in conferences. His topic is preventing and managing cardiorenal risk of diabetic dyslipidemia. So over to you, sir. So you can share your screen.
Okay. Share screen.
Sir, you can share the screen.
Yeah, I'm trying to do it, madam. There's some problem.
Yes, sir.
One, two, three. Yeah. Can you see, madam, now?
Yes, sir. You can make it full screen.
Good afternoon, everybody. See, I have a
Sir, your voice has gone. Hello, sir. Your voice has gone. Sir, your voice has gone. We can't hear you, sir. Hello. हाँ ना, so शायद उधर कुछ प्रॉब्लम है
Yeah.
तो
Hello, madam.
हाँ थोड़ी सर
Just I
बोला.
talked to Dr. Yatin Jog sir. अभी फिर से वहाँ से लाइट चला गया. So can we do
Yeah.
one thing, like maybe presentation I will send to IMA Pune mail ID, and
Yeah.
sir can join over mobile, so he can just talk from there. Audio will be there.
Okay.
And presentation can be run from
Yeah. So
your
let's
side.
do one thing. We can take another lecture.
Okay.
Or that will be because it will take time. You will be
Madam,
sent.
Madam, just a minute. Sujit, you can also share the slide. If you are
Yeah.
talking with my ID, na, you can also share the slide, and sir can talk.
Okay. Just one.
Yes. Nowadays, sir, you can try that. Sir, I joined on mobile. Please check whether sir has joined on mobile. Sir, I joined on mobile.
I'm just checking with calling him, ma'am.
Yeah. Otherwise, we can take the next speaker. Sir is there, Dr. Bharat Salve. So meanwhile,
Yes.
we can.
Yeah, ma'am. Just I talked with Dr. Yatin sir. So he is joining, and he just had the backup also now. Yeah, sir, I joined.
Yeah, he has
Yeah,
joined.
welcome, sir.
Yes, sir. Sir. Welcome, sir. So we can't hear you. You unmute yourself.
Yeah, I'll admit myself.
Yeah, yes, sir. Now we can hear you. Make it a full screen. Okay.
This is full screen.
Yes, sir.
So good afternoon, everybody. I'm a physician from Solapur. I know many of the speakers who are speaking, and all of them have given excellent lectures till now. I'll be talking on something called preventing and managing cardiorenal risks in diabetic dyslipidemia. Now, diabetes and dyslipidemia is a very common combination. When we started practice, actually diabetes was just a disease wherein sugar was to be controlled. There were some drugs available which were preventing or reducing sugar. Complications were something which were managed as they used to appear. Now there is a role of prevention. This is what is the topic for today. Now we'll start with one case. Vijay, he is a newly diagnosed diabetic, type 2 diabetic patient with HbA1c of 7.4, BMI of 24, blood pressure 130/80, total cholesterol 120, LDL is on higher side, GFR is 50, and he is on metformin 1000 milligrams and dapagliflozin 10 milligrams. Fixed drug combination was prescribed to him. Type 2 diabetes is a chronic progressive disease with burden of cardiorenal disease and dyslipidemia. Minimize करते हैं. Yeah. CV risk is associated with diabetes and high cholesterol, which is a well-known fact to almost everybody now. There is 7 times higher incidence of CV mortality in diabetic patients or non-diabetic patients with dyslipidemia. Coming to the next protocol, heart failure, chronic kidney disease, and type 2 diabetes mellitus are often comorbid. Heart failure is associated with 64 million people, whereas CKD is seen in 843 million people, which is a very high number. And we know India is going to be a capital of diabetes by about 2030, wherein we will see many more complicated patients. So our trial now is to reduce the disease burden and reduce the complication rate as much as possible. In type 2 diabetes patients, for the prevalence of diabetes is for 246 million. Of the 24% patients have heart disease, whereas 58% of type 2 diabetes develop chronic kidney diseases. And this is what is to be prevented at an earlier date. Cardiac function can be compromised early in type 2 diabetes. Of the 124 patients studied, 32% people had normal LV function. For 16% people had diastolic LV dysfunction. Systolic and diastolic LV function was seen in about 25% of the patient, and systolic left ventricular dysfunction was seen in about 27%. So almost everyone is suffering from some amount of LV dysfunction, and this incidence is to be reduced so that we prevent the complications. Patients with median LV dysfunction and absence of inducible ischemia they are the people who progress to diabetic problems and present to us with congestive heart failure, which is an earlier emergency now. Earlier diagnosis and management of left ventricular dysfunction and diabetic cardiomyopathy is important strategy in preventing clinically manifested HbA1c. See, there is higher 7-year incidence of CV mortality in diabetics as compared to non-diabetics. CV event rate is linearly rising with high cholesterol levels and 4 times more in diabetics with high cholesterol as compared to the diabetics high cholesterol with non-diabetic patients. Now, all UKPADS Accord advanced studies, these were the studies which were done for hospitalized fatal heart patients. The glucose heart management was a fundamental in the treatment. It doesn't reduce the risk of heart failure events, but controlled testing doesn't, heart failure occurrence is much low as compared to patients who are on uncontrolled diabetic disease. Next. See, optimal risk management is seen to eliminate diabetic nephropathy also. Now, this is another complication which is important. What we should treat is systolic and diastolic blood pressure. Systolic blood pressure less than 160 in conventional treatment, and in intensive management, it should be below 140. Diastolic, again, both are 85. HbA1c level should be preferably less than 7.5, but if it is intensive, you should reduce it to less than 6.5. Triglycerides, 2.2 nanomoles as compared to 1. HDL should be high. It should be 1.9 millimoles in regular phase, whereas this thing, and aspirin should be prescribed in almost all the patients who are, whether they are suffering from ischemia or whether they are not suffering. And other supplementations like vitamin C, E, the roles are still very not clear. With conventional treatment, there is 46% risk of nephropathy is reduced by 46%, whereas with intensive medical treatment, the risk is reduced to 25%. So this is a very significant factor, and it is important that we control diabetes optimally to prevent CVD at an earlier date. Now, what we need to consider in patients is patients like Vijay. He is a working person, so he should not get episodes of hyperglycemia, prevention of cardiorenal complications, and reduces lipid profile as early as possible. Now, what we should do for all this? We have to track the glycemic efficacy and the unmet need of cholesterol reduction. Now, add-on therapy with dapagliflozin resulted in significant reduction in HbA1c. This is what the chart shows. There's 0.44% reduction in DAPA metformin group, whereas DAPA metformin sulfonylurea group it is only 0.46%. And DAPA equivalent there is with add-on in combination with other drugs against placebo, the reduction in HbA1c is significant, and this definitely reduces the complications. Now, sitagliptin and metformin were also tried. The reduction is not as much as with DAPA, and DAPA with insulin shows the most significant reduction, but that can be additional therapy when it is required. Now, add-on therapy of DAPA results in significant reduction in body weight. Yeah, we are all seeing that as soon as you start SGLT2 inhibitors, there is significant body weight reduction. Again, with DAPA and insulin, the body weight reduction is not as significant, but plain dapagliflozin and metformin have reduced blood pressure significantly. With sulfonylurea combination also, it is reduced. And this is a beneficial effect to control diabetes and complications. Now, let's have a look at the prevention of cardiorenal outcomes. How to prevent kidney diseases and how to prevent hospitalization due to heart failure. Now, heart failure is a dreaded complication which occurs, and every time when heart failure, usually most of the people need hospitalization, which has to be corrected in due course of time. Now, the declare enrolled patients with early disease including those with or without atherosclerotic vascular diseases. The declared trial have shown the patients' risk of atherosclerotic vascular disease and patients with atherosclerotic vascular diseases with EMPA, REGA trial, with CANVAS trial and VERTIS trial. In general, type 2 population, only 20% of people have established CVD, but their tendency to progress into major cardiac events is high, and you should have a drug which will prevent all these factors rather than treat them after they come into. Yeah. Now, the declared has shown that dapagliflozin showed renal disease progression in patients with type 2 diabetic patients, predominantly with preserved renal function. Now, there is 47% risk reduction or renal progression reduction if you start dapagliflozin, so EGFR up to 86% and minimum of 30. If your EGFR is more than 30, less than 30, then you should prevent SGLT2 inhibitors at an earlier date. Now, what we see with dapagliflozin, as far as the effects on albuminuria, which is a first marker of renal dysfunction, micro to nanoalbuminuria, dapagliflozin has shown significant, that is 38.9% reductions from micro to normomicroalbuminuria or micro to non-normomicroalbuminuria. The reduction is about 40% as compared to placebo. With placebo, it is only 29%. The deterioration in baselines is seen commonly if the patient not started with albuminuria. Definition of albuminuria: microalbuminuria, urinary albumin more than 300, micro is 30 to 300, and normomicroalbumin is less than 30 milligrams of urine albumin in 24 hours baseline treatment. Now, heart failure and deaths due to heart failure are major adverse cardiac events. These are two factors which are considered in risk reduction of cardiac safety. With placebo, there were 496 events as compared to 417 events. So those there was a 17% reduction in the rate of decrease. Now, this reduction is significant because this is a life-compromising event and it usually leads to early hospitalization and failure. Now, patients who are on dapagliflozin see what is with dapagliflozin, what is well-established safety profile in patients with type 2 diabetes. Volume depletion is least with dapagliflozin. Renal adverse effects are low. Fractures are not seen. Amputation is seen in very little patients. Major risk of hypoglycemia is no. Usually there is no diabetic ketoacidosis. Genital infection is less as compared to all other SGLT2 inhibitors which are using. Urinary tract infection and Fournier gangrene are also seen in major. So, major hypoglycemia and diabetic ketosis, major complications of type 2 diabetes or early diabetic are avoided with patients who are taking dapagliflozin at an earlier date, and heart failure is also, progression is also very slow. Now, dapagliflozin in heart failure patients with reduced ejection fraction and heart failure patients and in patients with CKD. Patients with dapagliflozin and heart failure overall study, dapa 10 milligrams and placebo, they were evaluated in 4,742 patients, and dapa was well tolerated in patients with or without type 2 diabetes. Adverse effect rarely led to incomplete, and major incidence of hypoglycemia was not seen, but there was significant reduction in the composite CV endpoint, that is worsening of heart failure, 26% reduction. So, despite of having no complications, the CV safety was very well proved, and the benefits were seen also in renal. So patients going in with recurrent heart failure and with reduction, there was significant reduction in the all-cause mortality. Heart failure symptoms were low, and patients improved significantly better. With dapagliflozin started as a first-line therapy for Now, what we are seeing now is first and only SGLT2 inhibitor, which is proved with patients with CKD and with or without type 2 diabetes, and the cardiorenal risk and mortality are reduced significantly. Now, after starting SGLT2 inhibitors, there is 62% patients with type. What are the inclusion criteria? Patient more than 18 years, EGFR between 25 to 75, urine albumin between 200 to 5,000, stable dose of ACE inhibitors or ARBs were noted. Now, in the population included, there was 68% people who were suffering from type 2 diabetes and 32 patients were non-diabetic. The safety profile was dapagliflozin well tolerated even in patients without diabetes. Adverse events rarely lead to discontinuation. No events of major hypoglycemia. Again, all these benefits go on with everything, but the primary endpoint is EGFR decline was reduced by 39%, whereas all-cause mortality was reduced by 36%. So what more do you want? In a composite outcome, you should prevent a drug which does not have side effects and which reduces all the cardiac as well as renal safety profile. The CV death and heart failure was reduced by 29%, whereas the end stage progression to end stage renal disease was reduced by 44% in almost all the population. Yeah, now it covers the entire spectrum of cardiorenal population with atherosclerotic heart disease, dapagliflozin heart failure study, that is population with heart failure with reduced ejection fraction. Also, EGFR of more than 30. If the patient has EGFR of more than 30, then chronic renal diseases also, you can start the drug safely. The primary endpoint is heart failure or CV death. And EGFR decreased to more than 40%, then you should consider it, or renal death. There is a significant reduction in the cardiovascular deaths due to congestive heart failure at an earlier date. Now, what are the guidelines that are recommended for treatment? Yeah, this slide is probably seen by all of us so many times in this particular scenario of web seminars. SGLT2 inhibitors are recommended irrespective of diabetic. So diabetes is not a drug. So dapagliflozin should not be considered a drug only with as an anti-diabetic drug, but it should be controlled. It should be a drug which is important to prevent complications of diabetic and renal failure, CKD, heart failure, and CV risk, and whether the patient has established atherosclerotic vascular disease or not. It is important to start SGLT2 inhibitor at an earlier date. CKD patients and CKD patients with or without albuminuria, this is what is the protocol. SGLT2 inhibitors are only contraindicated if the EGFR is below 30. And at that time, you should consider insulin at an earlier date. Now, ACC and AC algorithm for glycemic management. Now, lifestyle modification, other things most of the people are following nowadays. Independent of diabetic patients with established ACD or risk, CKD, recommended SGLT2 inhibitors and LA. If at the entry time, if the patient's HbA1c is less than 5, you should start with a monotherapy. If the HbA1c is between 7.5 to 9, it should be started with dual drug therapy. If the HbA1c is about 9, you should start with triple drug therapy. If there are symptoms which are persistent, you should consider starting insulin at an earlier date and add another agent or intensify the insulin therapy. What is the monotherapy? Either metformin, GLP-1, SGLT2, DPP-4, thiazides, or sulfonylureas. Whereas dual therapy, we all know metformin goes constantly. You can add any one of the drugs at an earlier date, and bromocriptine, AG inhibitor, they are all tried. What is triple drug therapy? Metformin and any other drug, and you can choose a combination of any 2 or 3 of them, which will lead to a reduction in the albuminuria. And what with all the evidences that are available to us now, dapagliflozin is a drug which is safe and it can be started in dual or triple drug therapy also. Another factor which is important, all these drugs are just to prevent the LV function and LV dysfunction. What is the role of other component, that is lipids? Now, lipid levels are very significant. We all see many people in India with high triglycerides, high cholesterol as compared to other people, though they do not have, they are not overweight. So in healthy patients, normal artery, the endothelial dysfunction is present at the early level of risk. Secondary prevention of atherosclerosis in stable plaque, unstable plaque, all these pathophysiologies are known to all of us. When there is occlusion, you get acute coronary syndrome or infarction, which is a complication of high levels of cholesterol. Now, who are the people with any other following list who are at very high risk? The patients with established atherosclerotic vascular disease, either with previous acute coronary syndrome, unstable angina, MI, or infarct, stable, or patients who have undergone coronary revascularization, patients with history of stroke or TIS, unequivocal documented atherosclerotic vascular disease, including findings which are known to predict everything. Diabetes with target organ damage or at least 3 major risk factors established type 2 diabetes is a high risk candidate, and with patients with severe kidney disease also have a high risk category for patients with dyslipidemia. A calculated score of more than 10 for a risk of 10 years fatal CVD is important. Familial hypercholesteremia with atherosclerotic or with any other is considered. So in them, our target should be reduced LDL-C to 55. In patients who have diabetes with target organ damage, the diabetic dysfunction during the year is additional. They have 2 or more risk factors, and if the score, if the score is less than 10, you can target the LDL to less than 70. What is moderate risk? Young patients who are doing exercise, the sugar is well controlled, they are following the drugs and other things without any other risk factors like smoking and others, LDL should be less than 100. And with low risk patient, you can go up to LDL 116 mg/%. Now, intensification of statin before combination C. Treatment guidelines in diabetic dyslipidemia in patients with type 2 diabetes high risk, LDL reduction of more than 50% from the baseline, and LDL goal is less than 1.4 meeting is recommended. Patients with type 2 diabetes at high risk with LDL-C reduction of more than 50% and LDL-C up to 70. Now, statins are recommended in patients with type 2 diabetes, whether they have risk or no. What is the treatment of dyslipidemia? And you should intensify statin therapy as and when required as an internal combination. And the goal is not reached. The statins can be combined with ezetimibe. Guidelines are recommended a 50% reduction in LDL-C with atherosclerotic vascular disease. This is what is a chart which shows age. As the age progresses, you should try to reduce the LDL-C to less than 70, and target organ damage of cholesterol should be less than 190. There is risk discussion on emphasis on management and reduce the risk of risk factors. Risk discussion is important because the metabolically active, what is family history, history of chronic kidney disease, metabolic syndrome, patients with lipid biomarker, persistently elevated triglycerides, high HSCRP is high, LPA is more than 50. All these factors need significant intensification. If there is low risk, is the risk less than 5%. Borderline risk, if the patient is between 40 to 45 years of age, with atherosclerotic, with or without diabetes, there should be a reduction of LDL-C to less than 70. If LDL-C more than 90, no risk assessment or high intensification of statin is required. Diabetes mellitus patients with between the age of 45 to 70, moderate incidence of modification is required. Diabetes with 40 to 70 years and have other associated factors, LDL-C should be less than 10. What is risk? Initiate statin reduction to less than 50% of the baseline level at an earlier date so that the complications are significantly delayed. Now, what are major coronary events which are seen with, there is significant reduction in the 21% significant reduction in the cardiac major vascular events with a significant reduction in the LDL-C. LDL-C less than 7, the events go down by more than 50%, and whereas LDL-C between the levels of 70 to 100, the reduction is between the age of 17 to 15%, 24 to 15%. All these patients are high-risk candidates, so intensification of statin therapy is important. Now, this is what is seen. LDL cholesterol, the reduction of LDL cholesterol in treated patients. There is, when we start statins, there is 57% events are reduced if the cholesterol, baseline cholesterol is LDL cholesterol is reduced by 50%, and patients do not get many complications if this intensification treatment is started at an earlier date. Now, this is what was seen with Jupiter trial, the lipid profile and HRCRP from the baseline with rosuvastatin as a primary drug. HDL-C increased by 4%, triglycerides reduction by 17%, LDL-C reduction of 50%, and HSCRP reduction by 47%. So rosuvastatin was a drug which was used at an earlier date so that it prevents complications. It is proven significantly superior to the other molecule that was available, that is atorvastatin. With rosuvastatin, there is 44% reduction in CVD deaths, MI, strokes, and CV deaths, revascularization and fatal and non-fatal strokes, fatal and non-fatal MI, CV events in patients with CKD, and all-cause mortality. Everything was reduced significantly if the patient was started on rosuvastatin at an earlier date. Now, what is important now is that we should choose the right statin to treat all patients who are working in this category. Rosuvastatin was found to be effective in reducing LDL-C HDL ratio as compared to atherosclerotin in 16 week trials. LDL-C reduction was significant in patients who were treated with rosuvastatin as compared to atherosclerotin. There is a significant difference. Same way, triglyceride and LDL cholesterol was also, but LDL cholesterol reduction was most significant, so that this is a drug which will reduce complications at an earlier date. Now, this is choosing an innovator brand and researcher. This is a pharmacological trial, generics in India and bioequivalent. If the generic molecules are used, there is no necessarily lead to same therapeutic as compared to the innovative brands. If the outcome of clinical trials with therapeutic evidence shown that established by generic molecules. Innovator molecule is better. We could increase with other molecules. There is increased risk of side effects and there is reduction in the safety profile as compared to the molecules which are available at an which are produced by other companies. So innovator brand. So methylated asparaginase impurity was highly concentrated on generic brand. The impurity shows to have no inhibitory effect on HMG coenzyme, which is the factor which reduces, prevents the presence of impurity widely was available in the genetic versions of atherosclerotic as compared to the innovative brands. The difference was very significant. So superior density and desired LDL cholesterol reduction was seen only with original brands of statin as compared to the generic brands which are available. Innovative brands of formulation, they are active molecules of rosuvastatin. The impurity is very low. Rosuvastatin calcium, the impurity is high and impurity is again seen less. So whatever active molecule of rosuvastatin that was prevented, that is rosuvastatin calcium. This was a drug which was an innovative drug and that was used to prevent all the complications. Again, coming to the brand, as compared to innovative statins suffering from patients with cardiovascular, the generic drugs have shown average high risk of 31% as compared to generic brands. There is 31% more increase in the problems as compared to if you use an innovative brand, the complications are reduced significantly. So it is important to use a statin which is theoretically pure and it is an innovative brand for all these things. Now, cumulative probabilities with initial statin therapy in 5 years' time, generic statins and brand statins, this is what was seen. Now, dapagliflozin is having stereogenic center and bioavailability rate metabolism. It is a drug which is well tolerated without any complications at an earlier date. So it should be started as a first-line treatment in all patients who are suffering from cardiovascular disease, whether they are, and the cardiorenal benefits of original was explored with generic dapagliflozin. Again, now this is what we see with original dapagliflozin. There is outcome is better with empagliflozin, DPP4 inhibitors, approved treatment for CKD and CVD in 39 patients, reduce all-cause mortality of heart failure with reduced ejection fraction. Patients with CV death and reduced ejection fraction, patients show much better progression with original dapagliflozin as compared to this. Now, coming back to Vijay. After 12 months of follow-up with treatment with metformin and dapagliflozin, his HbA1c came down to 7, BMI came down to 22, blood pressure was controlled, triglyceride and other levels came back to normal, his eGFR was normal, urinary protein excretion was reduced. In summary, now DAPA is a drug which reduces hyperglycemia and lowers the risk of hypoglycemia. Ability of the drug to work at all stages with or without hyperglycemia, with or without diabetes is important. It reduces weight, blood pressure, and gives a significant cardiovascular protection. Rosuvastatin is superior to control LDL levels with therapeutic reduction in stroke, IMA, and revascularization. Compared to innovative brands, all-cause mortality with generics is about 62% high. Anyway, we don't go against any generic or other molecules, but this is what is seen. Thank you.
Thank you, sir. Sir, though it was a very difficult topic, you have taken in a very nice way and with all nice slides, you have actually explained us everything very well. So thank you very much, sir. Our President Madam is here. So I will request Dr. Meenakshi Deshpande Madam to felicitate you.
Thank you, sir, for an excellent lecture.
Thank you, ma'am.
Wonderful talk.
Thank you.
You are joined from Solapur. That is
Yes,
creditable.
Yeah.
Yeah.
And our webinars actually go all over Maharashtra and even beyond, because it's a recording done and they keep on seeing on YouTube also afterwards.
Yes.
So it's a treasure for them. Whoever sees such webinars, it's a treasure of knowledge for them. So thank you, sir, for a wonderful talk. This is our IMA Uparna for you.
Okay.
If you can come to IMA Pune anytime.
Okay.
Yeah.
Okay. Thank you.
IMA Uparna and a bouquet of flowers.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir. Sir had very much, so many technical problems, but he overcame everything and took his lecture. So thank you, sir.
Thank you.
Yeah. The next thing. The next lecture is by Dr. Bharat Salve. Sir, welcome, sir.
Thank you. Good evening,
Yes,
all.
yeah, Dr. Bharat Salve, he has already joined. So, welcome, sir. Sir is a director and owner of Dr. Bharat's Diabetes and Thyroid Clinic, Savedi, Ahmednagar. So, one from Solapur, now another from Ahmednagar. He's a visiting consultant diabetologist at Asian Noble Hospital, Heartbeat Multi-Speciality Hospital. He's an assistant professor at Dr. Vikhe Patil Medical College, Villard Ghat, Ahmednagar. Sir is a MBBS MD diabetes, is a renowned diabetologist and metabolic disorder specialist in Ahmednagar since last 6 years. He has treated more than 5,000 patients suffering from diabetes in last 5 years and earned trust of many patients in very short time. He's also a gold medal winner in the examination conducted by the United Diabetes Forum Group in the first International Conference Challenges in Diabetes 2015 and awarded as Best Resident Doctor at SL Raheja Hospital, Mumbai. He has got multiple publications in national and international journals. So over to sir.
Thank you. Thanks for kind introduction. Good evening, all dignitaries. Can you see my presentation? Am I audible?
You are audible, sir, but the presentation is not seen as it.
So double click to enter a full screen mode. We can't see your screen.
It is not opening. I am trying. Okay. There is some lag in my
computer. You are started screen sharing, but can't see your slide. No, sir. No, sir. We can't see.
Okay. Give me a second. Huh? Give me a second.
Okay, sir. Okay, sir. No problem.
Very well till now. Sharing.
Help you want, sir?
Right now, just it is some.
Depend sir is there. सर डबल क्लिक करून बघा येतंय का? तुमचं स्क्रीनच विजिबल होत नाहीये.
नाही हो करून बघितलंय. कॅन यू सी द स्क्रीन ओनली राईट नाउ?
नो, तिथे आपल्याला मेसेज येतोय सर की डबल क्लिक टू एंटर फुल स्क्रीन मोड.
म्हणजे युअर स्क्रीन इज नॉट
सीन ओनली.
ओके.
तुम्ही काय करा सर, आउट या. यू कम आउट अँड रीशेअर द स्क्रीन.
Okay, okay. I'm doing that. Okay.
Yes, yes,
yes. Yes, sir. Now you can make it full screen. Sir, make it full screen now.
Correct, correct. Yes, the whole screen has gone.
Depends, sir.
Internet connection is unstable because it is rainy here. Not that might be.
That's right. Because, from Solapur also the same problem had occurred. So can I request Mr. Nalaude
Yes. Can you see the screen now?
No, sir. Yeah. Now we can see, sir. Yes. You can
Okay.
make it full screen now.
Yes. Okay, extremely sorry for the technical problem. Can you see the screen?
Yes, sir. We can see the screen. You make it full screen.
Okay, I have done that. I have made it.
No, sir. We can see your slide, sir, but the screen is not there. Yeah.
Can you see the next slide? Second slide.
No, sir. They are not moving.
Visible, sir.
Okay.
Right hand la presentation mode असेल, sir.
हो आहे तिकडे प्रेझेंटेशन मोड केलं बरं का मी डन दॅट
Now they are moving, but screen is still. वर करता येतं त्यांना फुल स्क्रीन करायला त्यांच्याकडनं ते होत नाही त्यांच्या लॅपटॉप
होतं फुल स्क्रीन होतंय माझ्याकडनं तिकडे
पण आम्हाला दिसत नाही.
ओके
तर ठीक आहे, नाही जरी झालं ना तरी स्लाइड जर मूव्ह होत गेल्या तरी ओके आहे, पण ते
मूव्ह होतात का?
दे आर नॉट मुव्हिंग.
मूव्ह होत होते, एक स्लाइड एकदा मूव्ह झाली.
मूव्ह होत आहे सर.
ट्राय
स्लाइड मूव्ह होत आहे.
yes slides
moving, sir. You can continue, sir.
Yes.
You can continue.
So, good evening, all dignitaries. Today, we have heard a lot of talk about dapagliflozin. So, I am continuing the same. So, I will talk more on the primary prevention, particularly in type 2 diabetic patients, which are in the early stages. That is, they have not yet developed any microvascular complications. Those cases I am going to discuss now. So, how to reduce this risk of diabetes complication as early as and proactively in this continuum. As you are already aware, diabetes is a metabolic and vascular disease, and while it is not very important to control only glycemia, so it is a control. We have to prevent the further this micro and macrovascular complication, and how that better quality of life without complication we can give to the any diabetic patient. It is a very important in day-to-day era. As Dr. Job already said, when they started practice, it was only the glucocentric, but now we have to think about the vascular centric also. So I am taking my presentation ahead, and also one remark from Dr. Durairas sir. He said that 4 pillars are very important to prevent this cardiovascular disease. Out of that, I will cover the other 2 parts. That is the use of the SGLT2 inhibitor and beta blocker in type 2 diabetic patient. So this is a typical 47-year-old male who has been diagnosed of diabetes since last 6 months. And if you see, this patient is here at the time of diagnosis and already aware that is cardio-renal metabolic risk continuum goes with the multiple severe risk factor, that is smoking, overweight, hypertension, diabetic dyslipidemia, or we can say in general dyslipidemia, and diabetes. These are the risk factors which leads to this endothelial damage and causes this vascular disease, and it goes from the chronic kidney disease and heart failure. As you are already aware that the major cause of cardiac death into any diabetic patient is because of the cardiovascular disease, and that we are going to discuss. So in our case, we can see this from this risk factor, the patient, how it goes, as the years of the diabetes goes on, that patient develop the diabetic kidney disease and heart failure. That complication, that is landing into the multiple heart failure hospitalization, and most important is the CV death that we have to reduce in our day-to-day practice. So treatment of required in this our case is definitely for diabetes management is the SGLT2 inhibitor, and treatment and prevention of the cardiorenal complication we need that SGLT2 inhibitor and beta blocker that we are going to discuss in today's presentation. So what are the additional benefit of this SGLT2 inhibitor on and over this decreasing into the glucotoxicity? So most important, if you see the this HbA1c reduction efficacy of any SGLT2 monitor, any SGLT2 inhibitor is between 0.8 to 1%. So because of this decrease into glucotoxicity, it reduces this advanced glycation in product formation, and it also decreases the endothelial damage, and it is also having low risk of hypoglycemia. So this low risk of hypoglycemia because of this SGLT2 inhibitor is only because it is having mechanism of action which is insulin independent. So ability to work at all stages of disease is very important, but as the duration of diabetes goes on, the insulinopenia develop, and certain molecules, those like by causes, particularly insulin secretagogues, are not useful, when the patient develops the insulinopenia. But there, these SGLT2 inhibitors are really works wonderfully by causing renal glycosiduria and reduces the glucotoxicity. And another pleiotropic benefit are like weight loss, then decrease into the blood pressure, decrease into the your uric acid level, then decrease into your visceral adiposity. That causes then sustained weight loss, which is very important to reduce the further cardiovascular disease complication. And most important, it can be used as an add-on to the other oral anti-diabetic drugs. So these are the multiple clinical benefits of the SGLT2 inhibitor. So now if you look at the efficacy of SGLT2 inhibitor, that is the most important. Higher the baseline HbA1c. Here you can see when baseline HbA1c into this study is 7.92 there, you can see HbA1c reduction with the SGLT2 inhibitor is around 0.84. But as the baseline HbA1c was on a higher side, that is more than 9%, we can see HbA1c reduction with this SGLT2 inhibitor is 1.4%. Now I will stuck to the more to the dapagliflozin molecule now henceforth for the discussion. Now here, when dapagliflozin was added to the as a monotherapy add-on to the metformin, when it was added to the background sulfonylureas, then it was added to the metformin plus DP4 inhibitor, when it is added to the patient who are taking already OADs plus insulin, and when it was added to the patient taking metformin plus sulfonylurea. So there, when it was compared to the placebo, you can see the HbA1c reduction is significantly higher with the DAPA group compared to the placebo group. Now similarly, other pleiotropic benefit, that is the weight loss, we can see approximately body weight loss is 3 to 4 kg at the end of the study duration, that is 24 weeks, and higher the baseline BMI, we can see the higher the body weight loss. So that is very important, particularly to use this molecule into the obese type 2 diabetic patient, where we can get the significant weight loss. In my day-to-day practice, I have seen weight loss up to 10 kg with this dapagliflozin. Now coming to the other systolic blood pressure reduction, when it was given with the background ACE or ARB, or with the patient who are taking background ACE ARB with another antihypertensive, there we can see almost 3 to 4 mm of Hg systolic blood pressure reduction with this dapagliflozin. Now coming to the other important parameter, always we discuss about the sustainability of the oral anti-diabetic drug. And here we have data for the dapagliflozin is almost for the 4.5 years, that is almost 208 weeks. There we can see this metformin plus sulfonylureas was given to the one group, and metformin plus dapagliflozin was given to the one group, and there we can see the durability of this combination with the greater HbA1c reduction over the longer duration of 4 years. Similarly, body weight loss was compared with the glipizide. Then we can see the significant weight loss of almost more than 4 kg when it was compared, lesser hypoglycemia, and most important, here we can see the almost 4 millimeter of mercury systolic blood pressure reduction. Now here in this study, dapagliflozin was compared with the sitagliptin in Japanese population. This was the open label but blinded 8-point study, where they have looked for the primary endpoint in terms of the HbA1c reduction, proportion of patients who have achieved the HbA1c less than 7%, proportion of patients who have avoided the hypoglycemia, and they have seen also for almost how many percent of proportion of patients maintain more than 3% of the body weight at the end of the study. And in this trial, they have seen the larger proportion of patients, almost 24.4% with the DAPA group compared to the SITA, has achieved the primary endpoint. Similarly, body weight losses also measured with the DAPA. Gliflozin has shown the superiority over the sitagliptin, and also other secondary endpoint in terms of the glycemic variability or anthropometric measures and lipid levels. This DAPA. Our second case, here we can see this 52 years old gentleman who has been diagnosed type 2 diabetes since last 5 years, and he has developed this CKD staging G2A1. So we have this CKD staging as per the CKD EPI formula. They calculate the EGFR, and as per the KDIGO classification, they have classified this G1 to almost G5 category, and as per the albuminuria, they have categorized A1, A2, A3. A1 is for the non-albumin less than 30, and CKD stage G1 is when EGFR is more than 90, and CKD G2 is when your EGFR is between 60 to 89. So our this case lands into the G2A1, where there is low risk of the CKD. Now, if you see here, this current status of this patient is having hypertension. The current blood pressure is 130 by 80 mm of Hg. He is taking ramipril 10 mg and amlodipine 10 mg. His CKD status, as we discussed, due to A1, here is a typographical error. EGFR is between almost around 70 and normal albuminuria is there. Patient is having dyslipidemia with the LDL 77 and triglyceride 151. Obesity is there with the BMI 31 and current his HbA1c is 8%. And this patient has recently gained almost 3 kg. Amlodipine added to the ramipril recently to maintain the blood pressure. Then DP4, that is added add-on to the metformin 1 gram BID to maintain the glycemic control. And there is no other significant changes as made. And this atorvastatin 40 mg has been given for the diabetic dyslipidemia. Now, how to replace this dapagliflozin in this case to provide the window of opportunity, particularly for the primary prevention to prevent this cardiorenal complication. So here, these are the different trial, CVOT outcome trials till date has been conducted. This light blue portion is for the particularly primary carrier type 2 diabetic patient. There is no history of CVD or patient EGFR is like more than 60 milligram per deciliter. That is G1 to G2 classification as per the KDIGO classification. Now this is for the CKD population where the credence trial was done. Then this light purple color is for your particularly patient with the having high CV risk or those patients who had a previous history of myocardial infarction or heart failure. So this patient trials has been enrolled this high risk CV patient, and this Carmelina trial which has enrolled both the patient with the this CV risk and nephrology patient. So here, as we are discussing the primary prevention, this declared TIMI 50 years with the larger sample size, which is almost, I will say, it is almost 10 times more than the pioneer trial sample size. And this trial has been conducted for those patients with the having without any risk factor like CV or CKD and type 2 diabetic patient. It was conducted. Now here we can say almost more than 59% of patients were into the without no prior SCVD risk or no CKD has been enrolled into this trial, and 40% population had a SCVD high risk but no prior MI less than 2 years. So in this trial, almost all classes of the patient has been enrolled, but majority of class of patient were suffering from type 2 diabetes without any higher SCVD risk. And in this trial, they have seen this major adverse cardiovascular event has been reduced. Those patients with the prior MI and myocardial infarction, and particularly those with the heart failure hospitalization or CVD has been reduced into all the patients. Those who had a no prior SCVD high risk or patient who had a prior SCVD high risk or myocardial infarction. Similarly, progression of this diabetic kidney disease has been reduced into both the high CV risk patient and also without high CV risk patients. So here we can see if you give this dapagliflozin molecule, those patients were not having any CKD risk factor or SCVD risk factor suffering from type 2 diabetes patient, we can add after lifestyle intervention and metformin to prevent this further complication. I think this slide has been discussed by Dr. Jog already. So they have discussed this side effect profile of this dapagliflozin, which was compared with the placebo. And here we can see there is slight increase into the risk of the genital mycotic fungal infection with this dapagliflozin. But if you advise patient to take proper genital hygiene and proper hydration, we can avoid this genital mycotic infection with the any SGLT2 inhibitor. Then coming to the diabetic ketoacidosis, particularly euglycemic decay, has been observed on the smaller higher side compared to the placebo. But here we have to take precaution if patient is already taking insulin or long-standing type 2 diabetic patient is taking already insulin. And when you are initiating this SGLT2 inhibitor in such patient, so always advise that patient not to stop the insulin. We have to titrate or up or down insulin doses according to the glycemic control, but never advise to stop insulin, particularly during sick days. So that is the major reason to land this patient into the euglycemic decay. Now coming to this famous slide, each and every, I think audience also know this ADA 2022 position statement was published into the January month. And here they have classified patient after first line therapy, that is metformin and comprehensive lifestyle modification. They have categorized patient into those patients with the indicators of the high CV risk or established ACVD, CKD and heart failure. So here CKD and heart failure patient they are given after metformin, SGLT2 inhibitor as the second line drug, and those patients with the higher ACVD risk or those patients who are having indicators of this high CV risk, they have given the either GLP-1 receptor analog or either or this SGLT2 inhibitor can be utilized. And if there is no severe risk there also, when there is, we need to minimize the hypoglycemia, or if you want to weight loss, there they have given the SGLT2 inhibitor as the second line option. So here from this presentation we can see, if only cost is a concern in remaining type 2 diabetic patient after lifestyle modification and metformin, you can utilize SGLT inhibitor as the second line drug. Now coming to the, as per this ADA 2021 guideline, we have multiple evidences, but if you see, dapagliflozin has a good evidences for the primary heart failure outcome data is having with the dapagliflozin and empagliflozin. The primary renal outcome data we have with the DAPA and CANA till date. Reduction into the heart failure and CKD progression has been shown, better result all the three gliflozins. Now coming to the, this is a very novel evidence we have now, that is a dapagliflozin has been tried into the 30 type 2 diabetic patient, and they have looked for this body fat patterning. Then they have looked for the hepatic and pancreatic fat. They have measured this body fat and pancreatic and hepatic fat by this magnetic resonance imaging. They have used this proton density fraction technology to measure this fat. Also they look for this anthropometric measure, particularly your this waist circumferences, then skin fold thickness for the body fat measurement, particularly your tricep skin thickness they have looked. And they have done this study into the 30 type 2 diabetic patient, and they found that particularly pancreatic fat is a link to the reduced insulin secretion, and which is a more likely an individual with the pre-diabetes. So this molecule can also play an important role in diabetes reversal, because we have studied that when you give calorie restriction, there is always reduction into the pancreatic fat, and similar thing has been done with this dapagliflozin, and they have got this good pancreatic fat reduction. And definitely in future, if you have done the proper studies to look for the diabetes reversal role, particularly in pre-diabetic patient, we can get a good data. So no significant change has been found into the your lean body mass, particularly muscle mass. And this, in this study, they have also shown the improvement into the hand grip strength. That is, there is no deterioration into the muscle mass. And this finding indicate that the uses of the dapagliflozin has the potential to increase the muscle function, while the muscle mass remain the intact with the reduction into the good your visceral adiposity, pancreatic and hepatic body fat, and thereby reducing into the insulin resistance. So these are the promising data we have available till date. Now, how can you ensure the better efficacy or outcome while choosing the innovator? I think this slide has been discussed by the majority of speaker. What is the difference between the generic and innovator molecule? So this dapagliflozin crystalline formulation is from the innovator, and majority of generic formulation comes with the amorphous dapagliflozin. And this crystalline is a pure form, which is more stable compared to the amorphous molecule. And at a higher temperature with and increased relative humidity, this amorphous dapagliflozin is not stable, and its recrystallization reduces its efficacy. So that is the important difference between this both the molecule. Now coming to the what is the difference between the original and branded generic. So most important, we have large RCT data with this original molecule. We have large safety data. Then the sample size, if you see, this innovator molecule has been studied for the safety and efficacy into the thousands to the lakh population. But if you see the generic, they have done only the BAB study. They have proven the only chemical equivalence into the small number of healthy individuals, that is ranging from 60 to 30 healthy volunteers. And they have elaborated the drug development procedure from phase 0 to phase 4 has been available with this innovator molecule compared to the branded generic, which do not have that. So now coming to the our second part, that is thinking about the beta blocker use into the primary prevention. So managing sympathetic overdrive is very important, particularly in a high severity patient. Those are suffering from type 2 diabetes. So metoprolol reduces the sympathetic overactivity, as already know, and this is also chiral molecule, metoprolol. So average heart rate reduction with this metoprolol is around 14.53 beats per minute. And what are the uniqueness of this metoprolol is a rapidly and completely absorbed from your intestine, small intestine. Then half-life is only 3 to 4. That's why we have to use this extended release formulation. Excretion through the hepatic route, no accumulation of drug in late stage CKD, no active metabolite has been synthesized with this. So this is old, very old data, which was published into 1988. So here we can see this. This metoprolol was compared with the diuretic to look for the survival benefit into the high severity patient, and all cause death has been less with the metoprolol, and sudden cardiac death has been also less by relative risk reduction of 30% with the metoprolol compared to the diuretic. Now, what is a unique MPUS? So MPUS is a multiple unit pallet system which is utilized for this metoprolol by AstraZeneca. This is once a daily administration. Therapeutic plasma concentration is very smooth, so we don't get the ups and down into the concentration, and we get the steady state heart rate reduction. So less side effect and better tolerability is very important, and most important because of this ethyl cellulose polymer which is utilized for this pellet formulation, which gives the absorption which is not interfered with the food or any drug motility or GI tract disease. Now coming to the presentation, as we always talk about the secondary prevention. When any insult happens, then we think about the intensification of therapy. But when a type 2 diabetic patient comes to your day-to-day practice, so almost I will say 60 to 70% of the our day-to-day type 2 diabetic patient come for the glycemic control without any complication. But there we have to give the early therapy to prevent the further complication and give this primary care is very important. So increased risk of the cardiorenal complication, as you already know, dapagliflozin has shown the proven cardiac renal benefits from its trial like declared-TIMI, where it has been utilized as a primary prevention, particularly in heart failure patient and CKD. Then sympathetic overactivity increasing the most of the diabetic patient, and their beta blocker, beta 1 selective blocker like metoprolol, succinate has shown the reduction into the heart rate and thereby reduction into the CV mortality. Thank you. Thanks a lot. So these are the some package insert for this both the molecule, that is dapagliflozin and metoprolol. Thank you. Thanks a lot.
Thank you very much, sir, for your excellent talk. And you took little time to adjust and all, so it's okay because you are speaking from Ahmednagar. So thank you very much, sir. Now I request our President, Madam, Dr. Meenakshi Deshpande, Madam, to felicitate you.
Yeah, thank you. Can you hear us? Sir, can you hear us?
Yes, yes, I can.
Yes, thank you for your speech and your wonderful talk, sir. And I really appreciate your efforts to join in spite of heavy rains and bad weather. So this is a bouquet from all of us at IMA Pune.
Thank you. I will definitely.
And Uparna for you. Yeah, whenever you come to Pune, please come. Yeah.
So this is Uparna for you.
Thanks a lot.
And also I would request all the faculties also to promote our UCON, which is a Maharashtra State Conference. So it will be a conference for all women and gents together to register. Thank you, sir.
Thank you.
Thank you.
Thank
you. With this, we are coming to the last lecture by Dr. Vijay Mandora, sir. His topic is dapagliflozin for holistic management of diabetes and its complications throughout the spectrum. I'll introduce sir in very short. Sir is a MBBS and MD General Medicine from Pune University. He has worked as an honorary physician in Inlak Budrani Hospital in General Medicine and Department and Postgraduate Teacher in Medicine for DNB. He's a panel doctor for Telco, LIC, Bank of Maharashtra, Ruby Hall Clinic, Pune Hospital, Jahangir Hospital, and he's practicing since 1985, and he has published many papers. So over to sir.
Okay. Hello, good evening, everybody. Good evening, friends. Today we are going to talk about dapagliflozin or Forxiga in diabetes and its complication, and how we are going to use it in patients. Is it audible now? Hello, good evening, everybody. Yes,
Just a second.
Actually, just a minute. There is some technical problems.
Yeah. Sir, can you share your screen?
Yes.
Yeah, ma'am, we have shared the screen. Ma'am, is it visible? The screen is visible? Hello?
No, we cannot see the screen as yet.
Okay, okay. We'll just stop this share. Once again, we'll log in.
Okay.
Please, just a second, ma'am. I'm just 1 minute.
Now we can see something, but it's blurred.
Yeah. So now is the screen visible?
Yes, we can see the screen now.
Okay.
So please don't zoom then.
Yeah, you can go ahead now, I think.
Go to slideshow. Yes, ma'am, we are starting. Yes.
Okay.
We have Dr. Monroe, sir, on screen.
Okay. Good evening, everybody. Can you see me and hear me now? So we are going to talk about dapagliflozin in the management of diabetes and its complication. So as you know, and as everybody has seen these slides very often, when anybody who gets a diabetes over a year, he goes from multiple CV risk factors, like a person who is having diabetes, and if he has got multiple risk factors like smoking, overweight, hypertension, dyslipidemia, he slowly progress to heart failure, CKD, and atherosclerotic complication. Then there is a cardiorenal event or atherosembolic event, and there are complications of that events like repeated heart failure, hospitalization, and progressive renal functional decline, and dialysis, and heart failure or refractory heart failure, like that. So right from multiple risk factors, the person progress over the years to CKD and heart failure and cardioembolic events and all that thing. So we have to see how we can stop this from happening, and that's why we have to do it right from the beginning. So another thing, so that's why we have to control sugars quite tightly, because if you see 67% of the Indian patients, they don't reach their HbA1c goal. And as we have seen in UK PDS and all other trials, the earlier you control the sugar, there is a legacy effect. And if you control sugar right from the beginning, and if you control them within expected range, then the complications in long term will be very much less. So, but if you see the data which we have got, only very few patients are under control, and our sugar levels are not very well controlled in most of the patients. Many of these patients, fasting BSL is 148, PP-BSL is 220, or HbA1c is 8.2, while you know, the satisfactory control can be around 7. So our 66% patients are not in HbA1c control. Our 52% patients are not having their fasting BSL under control, and our 62% patients are not having their PP-BSL under control. So we need to do something more and better. And now we are going to see the role of SGLT2 inhibitors in the clinical scenario. So that is Forxiga. So what is a glucose lowering? So glucose lowering by SGLT2 is very important, because as we see, if you lower the glucose early in the course of diabetes, and later on also, it decreases the microvascular complications like retinopathy, neuropathy, and nephropathy. It also decreases the glucotoxicity. So suppose if you control sugar well, your pancreatic beta cell starts functioning in a better way, and they work for more time and more intensity. So glucotoxicity of the beta cells is become less if you control sugar properly. And another thing about SGLT2 inhibitor is there is low risk of hypoglycemia, even if it controls sugar so well. And because it has got insulin independent mechanism, it can work in all stages of the disease. And even if the beta cells are functioning or not functioning, it does work. And it can be combined with other classes of anti-hyperglycemic agents. And because if you know the mechanism of action of SGLT2 inhibitor, it causes glycosuria. And glycosuria, along with that, you got a lot of sodium loss and water loss also. And because of that, there is an initial weight loss. And there is some decrease in blood pressure that has been shown in many trials. And this is the only molecule which causes loss of excess calorie in the urine. So there is something which cause about 75 grams of glucose is lost in urine every day if you use this, and that causes sustained weight loss. And as you know, that weight loss is so important in a patient of a diabetes. And you know, whatever you do, this type of 225 to 250 calories, you hardly anybody can waste in a day by doing exercise or dieting. Another thing is there is weight loss, and this weight loss is for long duration of time. So maybe up to 4 or 5 years, the trial shows that there is a weight loss. So, and another thing, it also, if another anti-hypoglycemic agents like insulin, sulfonylurea, and TZD, if they are causing weight loss, then this effect is mitigated by giving SGLT2 inhibitors or like Forxiga. So multiple glycemic and extra glycemic effects are also there. And if you see this graph and what is actually usefulness of SGLT2 in diabetes, that it causes actually HbA1c reduction to the tune of 1 gram per cent. So 1%. So what happens if you start dapagliflozin at the lower HbA1c, then the HbA1c reduction is less. But if you start at higher HbA1c, and that happens with most of the drugs, the HbA1c reduction is to the tune of 1.32%. And another important thing is this additional effect of reduction of the HbA1c is there with the monotherapy. Even if you add it to metformin, it causes another HbA1c reduction. If you add to SU or sulfonylurea, there will be another 0.82% of HbA1c reduction. Then if you add it to any other agent plus metformin, still there is. So you add it to anything and it will cause further weight loss and further HbA1c reduction. Another thing, it also causes weight loss, and this weight loss is also proportional to the actually weight of the patient, whether it is a normal weight, overweight, obese, or very obese. It will cause around 1 kg to 3.41 kg weight loss in many patients. The more obese the patient, the weight loss is more. And many studies also have shown that it causes sustained BP reduction in patient of diabetes, and this is to the tune of 3 to 4 millimeter of Hg. And if you compare with reduction in HbA1c, and if you compare it with the sulfonylurea, there is at the 52 weeks, the reduction of the HbA1c is non-inferior to glipizide. So if you take long run, if you start sulfonylurea early, there is initially rapid sugar reduction. But if you take it towards 1 year or 2 years or more than that, then HbA1c reduction is similar to sulfonylurea. So it is equipotent to sulfonylurea. Then you can use it instead of sulfonylurea in any patient who comes to you as a first-line treatment also. Then this weight loss, what I told you, that it is around 4 to 5 kilogram as compared to placebo, and that they have observed over 5 years. And even up to 5 years, the weight loss is still persistent. So there is no, again, regain of the weight if you continue with the Forxiga. Then another very important thing is this blood pressure decrease, what we see, also remains there for many years. And it causes all these things, and the chances of hypoglycemia is 10 times lesser than with any other agent. So, and this all good things which dapagliflozin does, and still there is no hypoglycemia. And if you compare to sitagliptin, there are several secondary endpoints which is better. So as compared to sitagliptin, the reduction in cardiometabolic risk, fasting glucose, uric acid, and beneficial effect on heart and kidney is much better with dapagliflozin as compared to sitagliptin. So this is how there is a continuum of the cardiometabolic risk, and it risk actually increases from the beginning to many years as diabetes goes more and or patient goes become older and older. So what you have to do, there is a actually, if you intervene in the early phases, then this you can actually reduce many of these bad effects of the diabetes, like heart failure, cardiometabolic, renal, and actually heart failure. So this is how that particular patient, what we see. If you give them ramipril, amlodipine, you control their hypertension. Then if their EGFR is becoming over the years becomes less, then you use various other drugs like dyslipidemia. You use metformin, atorvastatin. We usually give to control lipids. And in that case, then now if you use DPP-4, then there will be further beneficial effect. So there is a window of opportunity for cardiorenal prevention in type 2 diabetes. And this has been proved with various trials, which has been done for the dapagliflozin. And now we are going to see these trials. So let's see what is the situation of the heart in patients of diabetes. So even if in early diabetes, if you study this patient of diabetes, you will find after say 4 or 5 years of person who is having diabetes, and if you even if there is no evidence of inducible ischemia, you find diastolic dysfunction in quite a lot of patients. And these diastolic dysfunction patients are usually obese, they are hypertensive, they have got early CKD, and they usually get exertional dyspnea with a small amount of efforts. And diagnosing them is very important because there is one trial which is preserved heart failure trial of SGLT2 inhibitors, and which shows there is a significant improvement can occur in this patient who has got diastolic dysfunction. And to diagnose that, you can also use NT-proBNP that you can diagnose many more diastolic heart failures than before. Then there are many patients who has got systolic LV dysfunction, or whose actually ejection fraction is less than 45 or so. Then there are some patients who has got systolic and diastolic, both type of heart failure. And there are very few patients who has got like 32% who has got normal LV function. So when the person who has got diabetes for many years, you have to actually look to do the 2D echo and look for the systolic and diastolic function of the heart. So, and even undiagnosed heart failure is common in diabetes. And if you really look for, you will get 23% patient with heart failure with preserved ejection fraction. And many times you will get patient with heart failure with reduced ejection fraction. So now, even if this microalbuminuria, which is very important, and you have to do actually ACR or albumin creatinine ratio in most of the patients. And why we have to do that? So if you have got albumin creatinine ratio more than 30 to 299, it is the hazard ratio is 1.5 for the cardiologic ACVD risk. So it is equivalent to your PKD of 30 to 34 actually, if your eGFR is 30 to 34. So diagnosing of albumin ACR is very important. And if it is more, there you can do the risk stratification, and these people are more having more risk for cardiovascular diseases. So how do we place dapagliflozin in these cases and provide a window of opportunity? So there is a window of opportunity where if you act early, you can prevent cardiorenal complications in most of the patients. Now, these are various CVOT trials, CVOT trials which are mandated by American FDA for any new drugs to see that whether they are cardio safe. And there are various trials with various drugs, DPP-4 inhibitor, GLP-1 RAs, and SGLT2s. And if you see on the x-axis, there is eGFR or the trials which are done with the decreasing level of eGFR, and on the y-axis, you have got more and more cardiovascular risk patients. And if you see, and why this is important, because in our clinic, what you see, patient is in early phase or day-to-day patient, they have got less risk of eGFR and less cardiovascular risk. For that, there is a declared TIMI trial, and we are going to see the result of it. Even if declared TIMI trial, if you use early dapagliflozin, it has been shown that it decreases the risk of CVD and renal failure progression. And there is been Credence trial and Carmelina trial, which is more for the kidney, and there are many other trials which are more for the heart patients. So declared TIMI 58th trial with dapagliflozin represents patient in typical primary care setting that we see in daily practice, where primary prevention of cardiorenal complication is the key. And this is how it works. That pump pipes is your blood vessels and filter is your kidney. And if you see, there are this actually TIMI trial is basically for the patient who has at the base of this triangle. And if you see that if you give dapagliflozin, it reduces the MACE or multiple intervention in the cardiac patient, like angiography, plasty, and all those things. And their MI risk is also decreased. But one very important thing is their heart of actually risk for hospitalization for heart failure is decreased quite a lot. And why it is important? Because like anybody who gets admitted for heart failure, then he has got very rapid downhill course for his heart failure, and the mortality is very high. So basically what we have to do is to prevent any patient's first attack of heart failure, and for that the dapagliflozin is very important. And another important thing about even this population is it decreases the progression of the renal disease, and it decreases the renal endpoints in all these patients. So even with multiple risk factors and actual patients which are less on the path of CKD and heart failure, here also dapagliflozin works very nicely. And this is a window of opportunity, and we have to use that window of opportunity. Now, this declared trial also confirms that it is quite safe to use dapagliflozin. And if you compare the side effects of dapagliflozin as compared to the placebo, if the difference between the two groups are not very significant for severe side effects, this DKA risk is a little high with dapagliflozin, but that is also very less, 0.3% in population as compared to 0.1 in placebo. And that is because in dapagliflozin, there is a glucose loss, and that causes ketoacidosis. And if somebody who is alcoholic or somebody who is having a low carbohydrate diet, these people are more likely, or somebody who is sick, or somebody who is on metformin, these people are more likely to get into diabetic ketoacidosis. But this incidence is very low. Amputation, fractures, acute kidney injury, and symptoms of volume depletion, everything is comparable to the placebo. Only thing which is little on the higher side is genital infections. And you know that genital infection with dapagliflozin or with SGLT2 inhibitor is because of glycosuria, and then it is better to have a good genital hygiene, cleaning the areas after passing urine and all that. That is very important, and usually they are fungal infection, and they do respond to fluconazole. Urinary tract infection is not very significantly high, but some people do get UTI, but very hardly pyelonephritis or septicemia. Corneous gangrene in few rare patients, and cancer of bladder is not statistically significant. So, management of blood glucose is important. Avoidance of obesity is important. Treatment of comorbidities is important. Obesity, you have to control hypertension. Then in guidelines, initially SGLT2 was introduced as third or fourth line drug, that is in 2013. But later on, now it has been 2021, the guideline incorporates latest evidence of SGLT2, and it is to be used in the primary prevention as compared to initially it was introduced later on. So even this new guideline also says that if there is high risk of ASCVD, CKD, or hypertension, or heart failure, then first line of drugs should include SGLT2 inhibitor. So SGLT2 inhibitors is recommended independent of glycemic control in patient with high CV risk, heart failure, in patient with high heart CV risk, heart failure with reduced ejection fraction, and also now heart failure with preserved ejection fraction, DKD, diabetes kidney disease, and albuminuria. So all these factors, if somebody is having, it is all guidelines say that you should include SGLT2 inhibitors like Forxiga. And if you see the level of evidence, the Forxiga has got evidence for reduction in heart failure. It has got evidence in CKD, reduction in CKD progression in all CVOTs. It has got good primary renal outcome data, and it has got primary heart failure outcome data is also very good. So all these three things are with dapagliflozin, as opposing to canagliflozin and empagliflozin, which lacks some of these evidences. So now if person is gone from early to mid to later stages of their actually risk continuum, then in that case also you can use SGLT2 inhibitor to reduce mortality, morbidity from heart failure with reduced ejection fraction and CKD. So, so heart failure is a major and growing public health problem worldwide. And if you see the incidence, it is, if you see global prevalence, it is around 1 to 2% of the general population, and much more in a patient who has got diabetes. And even CKD, if you take CKD, incidence is much more than heart failure, and it is in India, if you take Asia, India, it is 6.72% of prevalence of CKD. And this is DAPA heart failure. This is a landmark trial, DAPA heart failure trial, and it was very big trial. It actually enrolled 4,744 patients, and there were two arms. One is with DAPA 10 milligram and another with placebo. And what it showed significant reduction in CV death and worsening of heart failure, and there was a 26% reduction. And CV death reduction was 18%, and heart failure hospitalization reduction was 30%. So it is very significant. And another most important thing was these benefits were consistent across all. So it actually this trial have taken patients who are having no diabetes also, and this benefit was also applicable to the patient who doesn't have diabetes. So DAPA you can also give in patient who has got heart failure without evidence of diabetes. Whatever may be the baseline LVEF, whatever may be the heart failure background heart failure therapy, NT, Bro, PNP, or even if whatever may be the eGFR or diuretic use or no use, everywhere this benefit has been shown in DAPA heart failure trial. So risk of both first and recurrent heart failure events were quite down, and actually it shows reduction in all-cause mortality, and it was highly significant. P was 0.22, and heart failure improvement is more common, and deterioration was very less common. So it significantly reduced risk of CV death and worsening, and it is as early as 28 days. So graph started bifurcating at the as early as 28 days. So another thing about DAPA safety is it was well tolerated in patients with and without type 2 diabetes. Actually, it didn't cause a lot of hypotension also in these patients. And actually, this has been now recommended to start early if somebody has got a heart failure along with a beta blocker, and then you add the rest of the drugs like Arni and mineralocorticoids. So there is two trials about heart failure. One trial is of dapagliflozin and another trial with empagliflozin. And if you compare these two trials, so actually these are some points which I would like to discuss. That heart failure reduction was of the same magnitude. CV death reduction was much better with dapagliflozin. All-cause mortality was reduced much more with dapagliflozin. And onset, another very important thing about this trial, which was actually, they have found that those patients who were having no diabetes, and if you start them on dapagliflozin, there is 32% reduction of new diabetes in these patients. So it reduces actually development of diabetes in non-diabetic patients. And the ejection fraction benefit was very good with dapagliflozin, and quality of life is also much better with dapagliflozin as compared to EMPA. So this is how these two trials were actually conducted. Then heart failure guidelines actually mention SGLT2 inhibitors as first-line therapy in all patients with heart failure with reduced ejection fraction, and level of recommendation is 1A. So it is now well established, and it is in all guidelines also. So that's how you start. You start with beta blocker and SGLT2 inhibitor. Then step 2, you add ARNI, and then step 3, you can add MRA. And this is another thing is about DAPA CKD trial. So this dapagliflozin was started in patient who has got CKD, and actually it is also a big trial with number of patients is 4,304. They were actually, there are two arms, one with DAPA 10 milligram and another is placebo, and number of patients were 2,152. And inclusion criteria were anybody above 80 years of age, and eGFR they have taken 25 to 75. So early kidney failure to significant kidney failure, they have included all patients, and they are also included patient of urinary albumin creatinine ratio between 200 and 5,000. And most of these patients were already on S and ARB, because that is a standard of care for a patient who has got diabetic kidney disease. And most of these patients should be on S and ARB. So, and what they showed. So there was actually what were endpoints where there was actually if there should be endpoint was more than 50% reduction in eGFR, end stage kidney disease or renal or CV death. And what it showed that there is 39% reduction in all these composite outcomes, and it was very highly significant. So there is 44% reduction in composite outcome of sustained more than 50% reduction in eGFR or attainment of ESKD or renal death, and the hazard ratio was 0.56. And there is 29% relative risk reduction in CV death and hospitalization for the heart failure, and there is 31% reduction in all-cause mortality. So it achieved all the endpoints which it was actually studied for. And safety, dapagliflozin was well tolerated, keeping with its established safety profile. Adverse events rarely led to discontinuation of treatment. Very few events of major hypoglycemia or decay. So trial was actually stopped prematurely because it has achieved the endpoints. So this is KIDGO. KIDGO is actually a study group to study type 2 diabetes and CKD. And these are guidelines of KIDGO. There is first lifestyle therapy, physical activity, nutrition, weight loss. Then second life therapy, they recommend metformin and SGLT2 inhibitor. Metformin, you have to reduce dose after eGFR is less than 45%. And if eGFR goes below 30, then or dialysis, you should discontinue metformin. But SGLT2, if eGFR is less than 30, you do not initiate. And if there is a dialysis, you should discontinue. So the first line therapy is, of course, metformin and SGLT2 inhibitor. And additional drug therapy as needed is GLP-1, RA, DPP-4, SU, TZD, and in some patient AGI. So dapagliflozin now covers entire spectrum of cardiorenal continuum. So if you take patient population which are where risk of ASCVD is less than 40% and with multiple risk factors. So in that, and if eGFR is more than 60, so relatively early patient, they also showed the heart failure and CV death risk reduction is hazard ratio is 0.83, and even eGFR decrease is also hazard ratio is 0.53. So even in that population, it is useful. Then in DAPA heart failure, we have already seen that it is useful in all patients with even with low GFR, and patient who has got CV death or worsening and everything becomes less, and more than 50% sustained decline in that all criteria for CKD is also achieved in DAPA heart failure trial, and risk of relative risk reduction was 0.71%. And we have already seen DAPA CKD trial. So how can we ensure better efficacy or outcome? So you have to choose actually innovator or research agent, because crystalline is pure as compared to amorphous, that all we know. And crystalline dapagliflozin is more stable as compared to amorphous dapagliflozin. And what happens at higher temperature, and increases relative humidity. Amorphous dapagliflozin is not stable, and its recrystallization and chemical degradation may occur, resulting in lower efficacy. So you have to better go with original, and that is Forxiga. Thank you very much. Hello? Yes.
I think I will take on.
Yes, sir. It was a very nice talk, and it was, though it was very difficult, to make people understand, but you have made it very simple, and it really it's a means you require a skill to explain all these things. So one of the delegate from Mumbai, he was not able to join, so he asked for the link to listen to your lecture.
Okay.
Yeah. So thank you very much, sir. So now I ask our President Madam to felicitate you.
Just check whether there are any questions.
Yeah, there are no questions. No questions.
Okay.
Yeah.
I think the comparison which you showed, that slide was very good between the two drugs.
Empagliflozin and
even she has taken a photo.
I
of
have
it.
taken a screenshot of it.
Okay.
Yes, sir.
That was a very nice and educative. Actually, the slide was showing the gist of your talk, I think.
Okay. Yeah.
That was good. So thank you, sir. We felicitate you from IMA Pune with this Uparana.
Okay. Thank you so much. Thank you.
Okay, for you, for your wonderful talk.
Okay.
And, yeah, whenever you come to Pune, please make it a point to visit us.
I'm from Pune.
Sir is from Pune.
Then come and meet us, sir.
Sir, you were supposed to take lecture in our Multicon.
I will try.
Yeah, no. Last year Multicon you were supposed to take lecture, but because of some problem you could not take.
Okay.
I remember that.
Okay, I will this time.
Now this time you have to take, sir.
Okay, no problem.
Okay, sir. Thank you, sir. Thank you.
Thank
you very much, sir. So this.
Thank you, sir. Even now we are having 78 attendees over now here.
Yeah.
Thank you.
And it had gone above 100, and we have 150 registrations, sir.
Okay. Thank you.
Thank you, sir. And this whole program will be on YouTube. So anytime you can send that link. I'll be sharing the link with AstraZeneca people. So they will share the link with you.
Okay. Thank you.
Okay, sir. Thank you, sir. Thank you. Thank you very much, sir. So I think with
thank you all the delegates and
Yeah.
I mean and all the faculties who are waiting still.
Bharat Salve is still there, sir. Thank you for being here till the end. Thank you, sir.
Sir, can you all just open your videos? We can take a photo from here. Whoever faculties are here, can you just open your videos and we can take a photo so that
Dr. Bharat Salve,
Dr. Bharat Salve, Dr. Virendra Padwal is okay.
Yeah.
Okay.
I think
yeah.
Dr. Bharat Salve, I think he is not opening. So with yeah.
Yes.
Yeah.
Thank you, sir.
Okay.
Yes.
Thank you. Thank you. So with this, we'll come to end of this series of lectures on complication management in diabetes. So thank you very much all the speakers and all the delegates. So hope to see you in the next month in Boat Club.
UConn, yes.
For our UConn very unique conference with academic feast and extraordinary cultural bonanza. Means you can see all that things which conference doesn't have, with banquet and all the various competitions like recipe, rangoli and all. So you can enjoy that with your spouses also.
Both of you can actually register and enjoy.
Yes, sir.
The academics with the cultural festival which we are having.
Thank you, sir. It's a state conference.
Thank you, IMA. Thank you, sir.
Thank you, sir. Thank you. Thank you. Thank you, Pankaj. Thank you.